Geneva, Switzerland, and Ebelova, Cameroon, and over 80 countries where Teach to Reach participants have gathered and are connecting for today's plenary session. We'll be opening this plenary with the opening ceremony, and this opening ceremony will be led by Charlotte Mbou from the Women Who Deliver Vaccines Collective. Of course, everyone knows Charlotte, but the reason we're asking Charlotte to step up is because we'll be presenting for the very first time the Manifesto for Global Health open source version 2.0. We presented version 1 on the 16th of June at Teach to Reach 8, and since then we have actually collected and processed and reviewed and integrated the inputs of over 1,300 health professionals from all over the world. So we will start now this with the manifesto and then deep dive into a discussion with women who deliver vaccines as well as men who work alongside them around how have you made HPV vaccination work for girls and women. But first, the manifesto. Charlotte, over to you.
Thank you, Reda. Who are we and where do we work? While many of us have trained as health workers, we also come from other professional backgrounds. We are teachers, social workers, scientists, academics, and technicians. Some of us are volunteers. We receive little or no payment for carrying out health work in our communities. We come from all levels of health systems and are aware of the strengths and limitations of these large and complex organizations and the critical role of political direction and leadership in making these systems work. Some of us lead big teams at national or regional level. Others are responsible for specific areas of work within a local facility or across several facilities. Many of us work with poor communities. For some of the people we work with, healthcare is not a priority above economic activity to survive. The communities we work with may be geographically hard to reach, suspicious of government and by extension us, or hold religious or cultural beliefs that do not easily adopt the science we base our work on. Some of us highlight how decisions about housing, sanitation, and education affect the health of the communities we serve. But decisions on these things are made without reference to population's health needs. COVID-19 has for many of us highlighted the fragility of the systems we work in and our relationships with communities. For some of us, it has meant more investment and renewed political focus on healthcare. For others, it has meant cuts in key budgets and the rise of new threats to our work, such as rumors spread by social media. Many of us remember the fear of the early days of the pandemic and losing colleagues and friends, and often carried out our work without adequate protective equipment. For some of us, this period confirmed why we signed up to work in health. For others, this period was a source of mental stress and anxiety. Each of us is working in a unique context. The nuances of community structures, culture, and religion interact with the structures, image, and resourcing of our health systems. To be successful, we must make this interface work. Those of us who work in humanitarian contexts report further dimensions of complexity in our work. Our security is not often guaranteed. The facilities and equipment that we rely on may be targeted and destroyed, and our target populations may be inaccessible or displaced. Thank you.
Thank you very much indeed. This is the Manifesto for Global Health Open Source version 2.0, elaborated by over 1,300 contributions and contributors. I think almost an equal number that have led us to this version 2. Version 1 was presented at Teach to Reach 8 on the 16th of June. And after this Teach to Reach, every one of you will be invited to share your further inputs as we continue to strengthen and improve this document before inviting you to take it before global partners as well as your ministries of health, if that is what you choose to do. Now, this was a preamble to the Women Who Deliver Vaccines Collective, a Teach to Reach special event. This is again following and building on what we did at Teach to Reach 8. The very simple question this time: how have you made HPV vaccination work for girls and women? And a stark reminder: 600,000 new cervical cancer cases each year, 340,000 deaths each year, and backsliding vaccination coverage since the COVID-19 pandemic. So we're going to start and dive in right away now with Charlotte pointing us to our first speaker who is in our Zoom studio, who's been shortlisted on the basis of the experiences shared before Teach to Reach. Charlotte, who shall we hear from on this key topic of HPV vaccination?
Thank you very much, Reda. I have invited Boma Otobo to unmute herself and to share why, because just recently Nigeria introduced the HPV vaccine, and she was a key actor in this process, and we really want her to share how it has been over there.
All right. Boma Otobo, a warm welcome to you. You're a longtime scholar, leader in the movement for Immunization Agenda 2030. Do introduce yourself. Tell us who you are, what you do, and maybe also what you did in the past, and then tell us what you'd like to share about this HPV vaccination campaign in Nigeria.
Thank you, Dr. Reda. Thank you, Charlotte. It's always good to partner with you guys. I've learned a lot, and I've also improved on my work. My name is Boma Otobo. I last worked with NPHCDA as the Deputy Program Manager in charge of service delivery at the national level. Shortly after retirement, I got into consultancy with UNICEF, and I'm currently the Adolescent Health and HPV Vaccine Introduction Consultant to Lagos State. Yes, Nigeria should have introduced HPV vaccine on the 25th of September, all through to the 30th. However, the plan was shelved for several reasons, not because we were not ready, but we wanted the very highest level to be involved. And of course, if at the national level it's not been launched, then the states cannot go on to launch. And so for that reason, it was shelved to the 24th of October. And so we'll be having the 16 states that are in the first phase launching anytime from the 24th of October. And maybe just 4 states amongst those 16 states would also launch, I believe, the following week. And so for us, the target is 9 to 14 years. We've done the micro plan in Nigeria. We've been able to get our HR requirements sorted. Logistics have moved, especially the vaccines, devices, AEFI, because going to involve vaccinations, all of those arrangements have gone on. We also had what we called a rapid assessment, where we went into the communities, more like a research. We tried to find out the knowledge of the community members, school teachers, and so on, how they are able to understand what we're about to do. And we planned for 2, but the outcome of the first one showed that we still needed a lot of work to be done. And so the state and the LGs went back to the grassroots in engaging the communities, ensuring that we're carrying along the schools, sensitizing them, the mothers, the market women, different religious groups, traditional groups. All of these are ongoing. Presently, we are battling with a myriad of rumors against the HPV. And so we've rolled out the risk communication plan at all levels, where we are engaging people who are learned and also showing them the importance of the HPV vaccine. Like you rightly said, Reda, Nigeria records about 12,000 cases plus, where over 7,000 are losing their lives needlessly to something which can be prevented. So when you confront them with such data, they get to understand the importance of it. And I would like to say that Nigeria is targeting age 9 to 14, not because that's the most effective age for now, because we have the vaccines will not go around to the larger population that we love to target, and also for girls, because we're targeting the elimination of cervical cancer. And so the age 9 to 14 are our initial targets, because we believe that the girls have not been exposed at this point to the virus. And so as time goes on, we'll roll it out into the routine immunization schedule as from 2025. On this note, I would like to stop because I understand other speakers are here too who want to contribute. We're using the strategies of the schools, visiting the schools, and we'll also visit out of schools where we have girls within our target population in the markets, in the hairdressing salons, in the communities, churches, mosques, and so on. So on, several places where we can find them. And we'll have the routine, that is anyone that is missed during the campaign will now go into the public health facilities where we have the vaccines available and they can access. But at the public health facilities for the introduction, yes, you can get up to 9 to 14, but thereafter from 2025, it's going to be purely routine where each time can access it.
Thank you very much
indeed. We've
indeed.
engaged the media. They've done a lot of work for us, so thank you.
Thank you very much indeed, Boma Otobo from Nigeria. Obviously, a major campaign with a lot at stake around HPV vaccination. I'd like to turn to our guide on the side today, Laura Shimp. She is the director of the Immunization Center at JSI. Laura, good morning to you. Question for you. Now, you just heard Boma Otobo, who is involved from the national level. We're going to hear some very local perspectives next. But before Teach to Reach 9, you shared a quote in which you challenged Teach to Reach participants to get very specific about the discussion around HPV vaccination in order for that discussion to be useful. Can you first introduce yourself to everyone, and then who does not yet know you, and then tell us what is it that you're specifically interested in around this question of HPV vaccination?
Thanks so much, and hi everyone for joining, and my apologies to the Francophone team. Hopefully, they will have also a good, rich discussion. Like Rada, I speak French and English, and I have an affinity for both language groups. Right. But for HPV vaccination, particularly what we're seeing, and so I'm a immunization director for the center that provides technical support across many countries. We've helped with HPV vaccination introduction in at least 10 countries, including providing some support for the Nigeria rollout that's happening now, that was nicely described. So for me, I think a key aspect for the HPV vaccination, and I put some resources in the chat that hopefully will be helpful from the WHO collection of resources. What's really important is, as the previous speaker was saying, is to understand local context, to be able to really have that overall political will. And that political will needs to come from not just politicians, but also the other groups and partners who can be very critical for providing messages around cancer prevention, how we work with adolescents and adolescent health, the different partners that we can bring in from, for example, gynecological associations, particularly gynecologists who see HPV in their practice and can speak as testimonial to how vaccination can really help prevent HPV. So what I really would like to hear also from participants, particularly, I know there are several countries on here that have already introduced, like Cameroon, Zimbabwe, Tanzania, Kenya, to hear from them where they're seeing, particularly with out-of-school girls or with populations that may have had many questions about HPV vaccination, where have they been able to really turn that around to have confidence in vaccination, get youth advocates and cancer prevention advocates to really help us identify and reach those individuals who may have had concerns or not understood the vaccination previously, who now are part of the system and being advocates for us. I saw someone in the French chat mentioned the use of mother advocates for vaccination. It would be nice to hear some stories of girl advocates for vaccination and the types of, like I said, the cancer prevention testimonials and others who have really been able to build that confidence and trust and work with the vaccination program to reach people.
Thank you.
So thank you, and thanks to everyone for participating.
Great, thank you, Laura Shimp. Now, we're going to dive in now and remind everyone about the duty of concision, because there are so many, guests of honor who have prepared to speak, who've shared remarkable experiences that speak directly to some of the questions that Laura mentioned. For example, Zuhura Gaki Ahmed, your microphone is unmuted. And we have as well the story that you shared ahead of Teach to Reach. You said you visited women's groups and you talked one-on-one with parents, making them feel that they're part of this exercise. Now you're a community health worker working in Meru, in North Imenti North Municipality. A warm welcome to you, Zuhura. I hope you're going to be able to speak to us so we can hear your story.
Thank you, Mr. Reda. My name is Zuhura, as you have said, Zuhura Ahmed, and I'm very happy to be in this forum today. I've really done my best to make sure that our girls get vaccinated to prevent cervical cancer, that which affects most who have never received a vaccination. In fact, I had a challenge in some families whereby the parents were negatively accepting to this thing. They didn't want to accept on vaccination misunderstanding, thinking that this vaccination is for family planning, which of course is not. So I had to talk to them and make them understand that this is for prevention of cervical cancer. And to my country, this pandemic, I might call it pandemic, because a high percentage of women are getting cervical cancer. So I had to talk to them, teach one-on-one, make them understand,
Zuhura,
that this is.
Could I ask you, when you were with a mother or her daughter, you'll tell us which one, what were the words you actually used? Can you just tell us, model for us, what did you actually say that turned out to be effective in helping people understand and move towards acceptance?
Yeah, I told them that this is not family planning as they thought. So I made them understand that it is a vaccine that prevents cervical cancer. And that's how they came to agree to what I told them.
Okay,
yeah.
And why did they believe you? Can you tell us a little bit about the relationship you had with these? And were you speaking to the mothers or the girls themselves, or both?
Both, the mother and the girls. I talked to both the mother and the girls and tried to drive this understanding to them that this vaccine is of more help to them than what they think.
When you say,
I gave them an example.
Yeah.
I gave them an example of a certain lady who had this problem, and when she was asked whether she had ever been vaccinated, she said she had never been vaccinated. So I had to give them the example to show them this vaccine is more important, or it is important for each and every one of us to be healthy, and I mean to keep the disease at bay, the virus at bay.
So let me ask you this question. When you say I made them feel they were part of this exercise and we interacted freely, can you tell me what you actually did to make these women and their daughters feel that they were part of this, involved in this HPV vaccination effort?
Yes, it was about talking one-on-one, asking questions. They asked me questions, I answered their questions. That's how I made them feel that they are part and parcel of the conversation.
Thank you. All right, I'd like to turn now back to Charlotte. And thank you very much. I think we have to mark a pause here just to solve a technical issue. And thank you, Zuhura Gaki Ahmed. I believe next we'll be hearing from Tafu Rother, Muhanja Mutange. Let me just solve the technical issue. So, Tafarother Mutange, I hope you're able to unmute, and then we'll... All right, as we have your story ready, I hope that you are ready as well as one of our guests of honor for today's session. All right, looks like Tafarother is not able to respond at this time. Let's have a look in the chat. So we have some great, wonderful messages and dialogue already happening here. And Mary Juma says, well done, Zuhura Gaki from Meru. Dr. Opi Kansal is unmuted, Charlotte. So Dr. Opi Kansal, please introduce yourself and tell us what would you like to bring to this discussion.
Hi, greetings to everyone. I'm Dr. Opi Kansal from New Delhi, India. I have just joined as country advisor for American Cancer Society for India. And I just want to share, firstly, let me introduce myself a little more. I'm a medical doctor with a public health background. From 2000 to 2011, for 11 years, I have intensively worked in the immunization, working in polio eradication, and then the routine immunization in different arenas, including urban and rural, and also at the national level, acting as a national trainer in India and all parts of India. Thereafter, I switched gears for injection safety, infection control, etc. So I was away from immunization, but I'm excited to be back into the arena of immunization. So here, in the current context, we're in India, HPV, the cervical cancer, it's around 1/5 of the global burden, both in terms of the new cases as well as the deaths that is happening. And the update is that the government of India is still considering to introduce it at a nationwide as a part of the free under the universal immunization program. But in parallel, the organization like American Cancer Society, along with many other local non-governmental organizations, have rolled out an evidence-based communication material as well as scientific training material, which we called as the HPV vaccination, the science of HPV vaccination. So the project that we have rolled just around on 28 September is that the doctors, especially with the background that the medical doctors also themselves do not promote the HPV vaccination or HPV screening proactively. I mean, there are so many opportunities which are getting missed. So to motivate them, to give them a confidence about the vaccine, a large program of training the doctors in India has been rolled out. It's a virtual training program by the two biggest organizations like Indian Academy of Pediatrics as well as the Federation of Obstetrics and Gynecologists Society of India, shortly called as FOXY. So because gynecologists and the pediatrician are the first touch point for a lady who's likely to have a cervical cancer or a similar look-like symptoms, as well as a young child, 9 to 14 years of girls, who are the target age audience for the cervical HPV vaccine. So in summary, this program has been rolled out and it's in just around a week, but really, really good excitement that we are seeing among the master trainers who are getting trained. It's a virtual training program for leveraging fully the available technologies post-COVID across India. And we are pretty excited that over a period of time, there'll be a fundamental difference in the knowledge and awareness of the doctors, which in turn will lead into the mass awareness among the public, and the HPV vaccination coverage rate, at least in the private sector, those who can afford, will go up. We are hoping, and let's all pray that the government of India agrees to roll it out very soon. All tools are ready. I don't know why. I mean, there are some reasons that the nationwide rollout is still on hold.
Thank you very much, Dr. Opi Kansal.
Last thing, I wish to just good luck to so many countries that have been hearing that they have already rolled out, and good luck to you. We hope to learn from your experiences going forward. Thank you so much.
Wonderful. Now, Tafurola Mutange, who I was trying to get earlier, is now has a microphone unmuted. Mutange, I hope you are ready and able to speak to us, as you are one of our guests of honor. Tafurola Mutange, are you able to speak to us? I can see your microphone is unmuted, but we still cannot hear you, unfortunately.
Hello.
Yes. Okay. Wonderful. So good to finally hear your voice. You are a community health worker working in Kangemi around Nairobi,
Yes.
At a health facility, and you wrote about church leaders and school teachers helping persuade reluctant parents when it came to HPV vaccination. So you said, though most of the people were afraid of the vaccines, I had to use my time to talk to the people in the community about the importance of the vaccines. Some people started to listen and allowed their girls to be vaccinated. I was helped by my church leaders and also school teachers. With this teaching, they started responding one by one. My first question to you is, when you had time to talk to people in the community, can you tell us what words you used? What did you actually tell them that helped them understand the benefits, the safety and efficacy of HPV vaccination?
Yes. I first have to humble myself to have this opportunity to talk to you, Reda, and the health professionals all over the world. I used my time to go to church leaders and school teachers to organize for me people, parents, especially parents, to talk to them about the HPV, because at first they thought it was going to make their children, girls, to be barren, and the young women to be barren, not to give birth. But I had to talk to them, use sweet words. I told them it was important because it was just going to make them not to get cervical cancer. And that's how I thought. Sorry.
No, that's just some. Please proceed. We're listening.
So I talked to them. I told them the importance of getting the vaccine because it was going to prevent their girls and young women from getting cervical cancer. So I taught them how to go about how to prevent them, their children, because they had a negative thought that the children and young women are going to be barren after they have been vaccinated. But at long last, they accepted, and though they have not vaccinated all of them, but some of them have been vaccinated, and the others are still ongoing. So that is how it came. It came to give a positive solution to the problem.
Thank you very much indeed, Tafurola Mutange from Kangemi, Nairobi, Kenya. All right, we are going to hear a few more experiences shared. Charlotte, who shall be next? We want to keep in mind the balance between countries and genders as part of our rules of engagement for Teach to Reach. Charlotte will tell us who we're hearing from next, and then we'll go to Laura Shimp, who is our guide on the side for this session.
So Akelo Rebecca already has her mic open.
All right,
so we'll
wonderful.
We'll just guide you.
Yes, Rebecca, a warm welcome to you. What do you wish?
Thank you. Greetings to everyone. This is Akelo Rebecca from Uganda. I'm a public health nurse, and I'm directly involved with immunization in Kumi municipality in a health center 4. Yeah, previously in 2021, after the COVID, there was a lot of hesitancy in a vaccination generally, including HPV. But and that is the very time we had a rise of teenage pregnancies. So I used data of teenage pregnancies, and I visited the education municipal officer, and then I shared with her that we needed to intensify school health And one of the things that I had in mind to do was to do HPV vaccination, and then TD, that is tetanus toxoid, previously known as tetanus toxoid, and then also to educate on teenage pregnancy, its effects and the complications to a girl child. So when we had a dialogue with the municipal education officer, we zeroed down that we invite all the head teachers of the primary schools and the secondary schools within the municipality for a meeting. And when we had that meeting, it was so successful that we drew up a schedule. Each head teacher gave me an appropriate date to visit the school. And indeed, we organized the schedule and we implemented that. And every school I visited with my team, we had all those services given. First and foremost, for them to accept the vaccination without the consent of the parents, it was difficult. So during the AGMs, they asked me to go and give a talk on HPV vaccination and any other adult vaccinations related to the children, because they get consent, they get them before the parents even consent, since it is a school program. So when I talked to the parents in AGMs, they openly said it's okay as long as you know the vaccine has no problem. But others still said, I think we hope you're not bringing COVID vaccine, because they were really against COVID. But after a long explanation, I had to draw for them the uterus and locate where the cervix is and how the vaccine will prevent the cervical cancer. They really appreciated the science behind that. And now we penetrate the schools, we do the vaccination without any hesitancy. And that is my success story in the municipality. Even right now, we are implementing integrated child days plus. So where we go with HPV, tetanus, diphtheria vaccine, and then also other educational topics to do school health as well as vaccination. Thank you very much. Back to you, Reda and Charlotte.
Thank you very much indeed, Rebecca Okello from Uganda. Yes, back to you, Charlotte.
Okay, thank you very much, Reda. So in terms of gender and geographical equity, I think we'll listen to, Anu will listen to Michael Jones, and then we'll end with Anu just afterwards.
There's also Dr. Suresh Shukla.
Yep. Thanks, Charlotte and the team. So for us here in Sierra Leone, the HPV introduction was really a successful before the introduction. And then we had real engagement, and we decided to have the HPV introduction as integrated introduction. Intersectorial engagement, the Ministry of Education was involved, Ministry of Local Government was involved, and then the Ministry of Gender was involved. And then we all collaborated together in the rollout of the HPV vaccine. And we ensured that the integration, the sensitization and orientation goes down to the chiefdom and the village level, wherein we engage at all level tribal heads, we engage local and traditional leaders, and we engage women, influencers, women in the various districts. And we established technical working group in all of the districts, which coordinates the HPV rollout and the introduction. And then when we faced with the situation where we didn't have enough money to roll out the HPV vaccine across the country, we decided that we should integrate HPV with COVID-19. So that was the first time we did an integration of COVID vaccine. So we use HPV vaccine and COVID-19. We integrate it alongside vaccinating girls at 10 for the HPV vaccine, and then of course vaccinating boys and girls at 12 for the COVID vaccine. And then this was a very, very successful introduction, and we even had achieved the coverage more than what we were expected, the targeted number what we were expected. And we used to approach school-based vaccination where we go to schools, engage the teachers, and get the teachers line up the kids and get them vaccinated. Then, of course, we use the CHW at community level in identifying and line listing girls who are at targeted age 10, and then get them assembled at critical location, and the vaccination team comes and vaccinates them. We are able to have issues related to refusal, especially those from the private school, because we earlier engaged the Association of Private Schools, and the first girl who was vaccinated was a girl from a private school. So that sends a clear message to the private schools who normally refuse vaccines or refuse access of health care to their schools, and then giving us the room to come in and get the kids vaccinated at the schools. But in a nutshell, the success of our story is because we decided to integrate HPV and COVID-19, and we're able to have a greater impact in terms of having girls vaccinated with HPV vaccine at 10 years in schools and out of schools, and then of course boys vaccinated with COVID-19 vaccine at 12 years in school and out of school. And then this is a story that we would love to tell, and this is something we've enjoyed, we've seen. Then after the introduction, we decided that HPV should continue to be part of the routine. But then we try to include it part of the outreach sessions that the facilities will go to community and schools. But then in our periodic intensification of routine immunization, the PURI, we added HPV as part of the routine vaccine, which should be taken along with healthcare workers when they are going on their outreach to communities, especially in identifying zero-dose children. HPV vaccine was part of it, and they were able to reach out to us at school. As part of our PURI exercise, we've vaccinated over 50,000 girls with HPV vaccine since the introduction. And at the introduction, we are able to vaccinated over 170,000 girls in school and out of school. So this is a good strategy that we use in introducing HPV. Over to you, Charlotte and Red.
Thank you, Michael Jones. Now, we heard about Sierra Leone's HPV vaccination success story at Teach to Reach 8. So we're glad to hear this follow-up, and look forward to hearing more as you maintain and continue to grow your efforts, and to continue learning from that. Thank you for joining these sessions. Now, Dr. Suresh Shukla has been sending messages. Dr. Suresh, we'd love to hear your success story, lessons learned, or challenge around HPV vaccination. We've obviously gone over time. We knew this would happen. We should have I just forgot to announce it, to say we'd be spending a little bit more time than the 30 minutes initially allotted on this question. I also want to acknowledge, before we hear from Dr. Suresh Shukla, the many mostly greetings. So please, we're asking specific questions, success story, lesson learned, challenge around HPV vaccination, but we are getting some right now we're getting mostly greetings. So Patricia, Ido Collins, Husseini Garba, for example, Asad Ali, Abdullahi Mohammed Takai. Really, the point is for you to share your experience once you have said hello, of course. Now, Dr. Suresh, over to you. What is the success story, lesson learned, or challenge that you'd like to share about HPV vaccination? And just as a reminder, this is not about general opinions about the subject or theory about the subject. This is really about things you have actually done, carried out, and what you learned from that. But please do introduce yourself first.
Good evening, everyone. I am Dr. Suresh Shukla, working as a surveillance medical officer in the World Health Organization, IPD. I've been working since 3 years. This is the first time our country demonstrates HPV vaccination, and there is few amount of vaccine.
Sorry, can you tell us which country, Dr. Suresh?
Nepal, NEPAL, Nepal.
Thank you.
Yes, sir. Let's go. First of all, when we in the process of introducing the vaccine, there are a lot of rumors in the community. So first we catch the governance, like local government, provincial government, and federal government, and advocacy with them. After that, we move towards the school teachers, like some district authority, provincial authority, and advocacy. Have a meeting, orientation, technical as well as practical things, and other country research, how they success. After that, we are planning this vaccination in the tertiary level hospital, because many people afraid that maybe AFI comes more. So we start from the tertiary level hospital. Every province, one hospital we choose and announce. First of all, we give priority on the media communication. How to get communication up to the community people or school children who are the targeted group. And our program, we are just providing the 14 and 15 years, just that age group of females. And these things, even when we start the campaign, 1 or 2 days, there was 5 days campaign in whole country, and 2 days in tertiary level hospital, very few client comes for the vaccination. Then we have changed the plan and moved towards the uh, community and educating more community people. And we use, our country have the female child health worker who is supporting in the immunization program as well as nutrition and other, and they are counseling with the females who are not going to school. Children are comes from the school, but those living in the community, these female child health worker are bring them, and we are getting success to give vaccination to that age group of females and the girls. And there is no any AFI, and very good story. First we need to media communication and orientation to health worker first, and the leaders group, like some religious groups, religious leader, we find some religious groups, they are totally denied to get this vaccination. There is a bad rumor that before marriage taking this vaccine, something rumor like that. When we catch the religious leader, we counseling them, advocacy them, then we found that things, faith healers, traditional leaders, and to reach the community, we are apply that type of our planning, and we get success in our HPV vaccination our country, and we get good success and coverage. Thank you, sir.
Thank you very much indeed, Dr. Suresh Suklasha. We are over time with this session. I do also want to go back to Laura Shimp, our guide on the side for this session, to hear really, it's going to be difficult to give us a concise synthesis, but maybe the three key takeaways from the discussion so far. We'll hear maybe from one other person, and then we'll be shifting over to the topic of measles outbreaks. And if this leaves you thirsting for more, that is exactly what we are hoping, because the heart and soul of Teach to Reach is not in these plenary sessions where you'll hear just a few people speak, but it's in the individual networking that will be opening up after this session, and you can join. You can choose or alternate between networking and plenary sessions. Again, to demonstrate how this works, you go to the speed networking, and then when you're ready to meet someone, you click on join. I tried to, but didn't succeed in demonstrating that in the tutorial session, but it does work, and we've seen hundreds of participants actually join these networking sessions. So Charlotte, maybe one more person, and then and asking that person to be especially concise, and then we'll shift. We'll ask Laura for her three key takeaways. Charlotte.
Right now we are going to end with Anu. Sorry, Darius, it's gender equity at play.
Okay. All right. So greetings, everyone. Thank you, Charlotte. Thank you, Reda, for this opportunity to share my experience on HPV vaccine in Nigeria. So just adding to what Professor Boma has said again, is that one of the good things that Nigeria has taken on is the inclusion of the civil society in the advocacy and mobilization.
Sorry, Anu, but I don't think you've told us who you are or what you do.
Okay, so my name is Anu Rotimi. I'm joining from Abuja, Nigeria. I'm a civil society practitioner. I'm a immunization advocate, and I keep on advancing attainment of universal health coverage. So yeah, thank you for that. Sorry, I missed that part. So in addition to what Nigeria is doing in terms of the high-level political mobilization, integration into the PhD advancement, is also the inclusion of civil society in the advocacy and mobilization and sustainability of the uptake of the HPV vaccine. And thanks to Gabby, we are working with partners such as the Women Vaccine Advocacy Group, CSOs around the country, and especially in the first 16 states. were selected, some were selected and trained, and some of these CSOs were also expected to step down to training to their other civil society. And the CSOs were actually equipped with some IEC materials to help disseminate information around HPV. So one of the things my own organization were able to do is that we are working closely with what we call the World Development Committees and the agreement associations and parent associations, because we know that girls between the age of 9 to 14 require parental consent to take any form of vaccine. So even as much we're also informing them at schools, we're also reaching out to the parents on guidance to give these children the right to take the vaccine. So one of our learnings is like there are already some misinformation made around the vaccine, around that, is it going to prevent fertility and the rest? But we made them clear that the vaccine is safe, and we also use this slogan that vaccine is good in our awareness and mobilization campaign. So also, one thing that has also worked very well is that we don't go to them and tell them, come and take vaccine. We share the experience from first. Do you know about cancer? What do you know about cancer? What type of cancer do they know? And if they mention cervical cancer, we now dwell on the cervical cancer as well, in as much as there are different types of cancers, but we are lucky that this particular type of cancer, which is cervical cancer, has a prevention mode, which is actually preventing girls from actually the HPV virus advancing to cancer at the later stage in life. So they have the opportunity right now to prevent the young girls from cancer, so we can have a future generation that is free of cervical cancer. So that message is actually resonating so well with the community, with uptaker, with girls, with the parents. And in fact, the concern now is that they're now feeling, why won't even older girls also have access? Why won't older women also have access? So they don't have to also be victims of cancer. Also, they're also advocating, one of the people we are getting back from the community is also to have to ask you to conclude, boys please. And girls, to include boys and girls in the vaccination. Thank you so much.
All right, thank you, Anu. Super interesting, but again, we have so many people who are waiting to speak. I again you call on your duty of concision out of respect for fellow guests of honor and speakers who are here. And I'm going to ask the same thing from our guides. So first, Laura Shimp, if you could share 2 or 3 concise takeaways from this, from the many different. I'm sure we could spend hours more discussing, but that is not how the learning process actually works. We're going to mark a pause here with feedback from Laura, and then Deepa Pokharel from UNICEF, ahead of our zero dose session, but very much involved, who leads demand for vaccination at UNICEF, also will have some feedback for participants. So Laura, 3 takeaways, and then Deepa, concise feedback for everyone.
Thanks so much to everyone. Great contributions, and I'm sorry that we can't hear every one of them. I think we could be on for 3-4 hours. 3 main takeaways. One, the great examples that have been shown about the importance of having girl advocates and peer-to-peer learning between girls, so that those who've been vaccinated or those who know more about vaccination can help convince and console the other girls. No one likes injections. So, help to address the protection and other things. And secondly, the importance of working with cancer prevention groups to really help people understand this is an incredible cancer prevention vaccine. Like, we have a way to prevent a cancer. And, trying to get people motivated about that, because HPV is such a killer of our women and mothers and others. We want to prevent it. And thirdly, the important aspects that were mentioned around linking with ministries of education, religious groups, and others who can help us link with communities best and link with schools, so that we have a holistic approach. Immunization can't do this alone. We saw that with COVID also. So really being able to have those long-term partnerships with those who can help us reach the communities that trust them. Thanks.
Thank you very much, Laura. Over to you, Deepa, and please do briefly introduce yourself. You'll be our last person to speak on this topic, as we're shifting to measles outbreaks, and equally, without wanting to compare which one is more urgent. Deepa?
Thank you, Reda, and thank you, colleagues. It's been incredible session. My name is Deepa Pokhrel, and I am with UNICEF headquarters. I lead the vaccine demand work for UNICEF at headquarters, and as obviously HPV is one of the things among many other things that UNICEF supports across 150 countries across the world, including many of your countries which you've already mentioned: Kenya, Nigeria, Uganda, India, Nepal. So just a couple of points. It's been really educational to hear the real experiences from colleagues. I wanted to narrow down on a couple of things. Some of you touched upon the need to have rapid assessments, but I think it's a very important start to, when we say data, we don't have to think of a CAP survey, which takes like a long time, but really listening to what the girls have to say. What do the mothers and the community leaders have to say? What are their concerns? Because that's the starting point when we start looking at co-creating solutions, which is informed by the local data. I really want to ask and request the participants who have spoken. I'm sure that you're already doing it, but just to emphasize, it's so incredibly important to hear from these young people because they have a mind of their own. So here, HPV vaccine is a life course based vaccine where we are dealing or we are working with two or three different populations. Normally, we would just talk to caregivers, but in this case, the young girls, as Laura already mentioned about how do you actually engage girls. And there's a tremendous amount of work that is being done at the country level, community level. The second point I wanted to touch upon is misinformation. Like in every other new vaccine introduction, HPV also comes with a fair share of, actually even more than other vaccines in terms of misinformation. So we do need to be ready to have a system in place where we have a mechanism to listen to communities and address them really quick, in a quick turnaround. I'm not talking just about the social media, but also the community conversations from different people who are talking about it, and then have our influencers, which many of you already touched upon, about whether it's pediatric association, whether it's religious leaders or communities. And the third thing I really wanted to ask is, based on the community engagement tactics, which has been used by many colleagues across the world, and some of the fantastic things that we heard. Mass media is one thing which can create an enabling environment. But when you are talking about uptake of the vaccines, media engagement is not the only thing which is going to work. That's what the experience shows and the data shows. So I really encourage that we engage our communities right from the beginning, from the time when we are collecting data to the planning and then implementation. But thank you so much, colleagues, for the wonderful work you do across the world. And it's really been such an educational experience. Thank you, Reda. Over to you.
Thank you very much indeed. Deepa Pokhrel will be joining as a guide on the side for our zero dose session, but is very much involved in these issues, of course. And now we are switching topics, still on immunization. As a reminder, Teach to Reach 9 is not focused only on immunization. You'll be hearing, we'll be exploring other topics. You can consult the schedule. Just as a reminder, if you are not here right now, you're not getting the full Teach to Reach experience. One of the tools that you have at your disposal is the schedule. So you can see right now there are definitely some people networking during this period, and then we are currently in the main plenary where we're going through a number of different topics. At the top of the hour, I'm not going to say what time because it depends where you are in the world. For me in Geneva, it is 4 p.m. We'll be splitting up. Some people will go to meet the Gavi Zero Dose Learning Hub, and that is taking place in the Hopin platform inside a session. So the only way you'll be able to actually attend that session with Gavi is if you go to the sessions inside Hopin. We'll share the direct link when the time comes. Now, that is not the only thing happening. If we to go back to the schedule, at the same time, we'll have a presentation of 2 research papers on the movement on the sustainability and impact of the movement for Immunization Agenda 2030. So this will be presented by Bridges to Development together with IA 2030 movement leaders who contributed to the research. Some of you will go to network, and then those of us who stay on the stage in Hopin or in the Zoom studio will then join the UNICEF plenary focused on zero dose in urban settings. That will be followed by sessions on From Community to Planet. So this is about health professionals on the front lines of climate change. And we'll be ending this Teach to Reach. So more networking alongside that, and then going to neglected needs of women's health, where you'll hear experiences shared in the fight against female genital schistosomiasis. So as you can see, a packed program today. But right now, we're going to talk about measles outbreaks. And we're going to turn to those of you who shared your experiences. You have been invited as our guests of honor, and we're looking to listen and learn from your experiences. As always, I turn to Charlotte, who's going to help us find our first speaker for this segment on measles outbreak. What we're interested in is what you did to respond to measles outbreak. What would you like to have done better? What has been most helpful to improve? And what are the most difficult challenges you face now? So I'm guessing Isha Goyal, whose microphone is unmuted, is up. Isha, a warm welcome to you. Tell us who you are, what you do, and then share. Don't forget to introduce yourself.
Thank you, Reda. Good morning, good afternoon, and good evening, everybody. I am Dr. Isha Goyal. I work as surveillance officer in World Health Organization and working in the field of immunization since 7 years. So recently in this 2023, I had a lot of measles outbreaks in my district. And what we have done to control the measles outbreak is we have prepared a line list and we have a system of listing all the cases. So in India, let me explain some basics. Village is the lowest point. Multiple villages constitute a subcenter and multiple subcenters constitute a block. So block is the unit where we flag the outbreak, and as soon as the outbreak is flagged, we do a preliminary investigation there to find out more cases. And if we found more cases there, then we do a detailed investigation there in which we go house to house to find fever rash cases currently or in the previous 3 months. This activity is done and supervised with the help of World Health Organization. So we try to maintain the quality, but the improvement is required in this only, that the government officers and the government staff should be sensitized to this level that they can do without the support of WHO. This is the improvement point which I need in my district. And the one thing which I noticed is, after analyzing the data, that 90% of the cases were in a single community and most of them were unimmunized. And I have been listening the HPV vaccination also, and I have worked in introduction of the new vaccines in my country. And in multiple scenarios, there is same community who resist for vaccines every time. So I have listened the previous session also that people have involved the religious leaders, community leaders, but that is my concern, that in my district, I have faced this situation that every time the same community and same people are there who refuse for vaccination, be it polio vaccination, be it measles vaccination, be it COVID vaccination, or maybe in future when we will launch HPV vaccine in India. So this is my concern, that whenever we find or design some strategy at the local level, that is good, but at the global level, we also had to find out that whether the same communities or the same population are refusing the vaccines every time, because it's a need of ours to take action at the global level also along with the local level. And regarding the measles outbreak, I want to add one more thing, that after the measles outbreak is identified in any area, we try to convince the people to get their children vaccinated with the MR vaccine, which is in the Universal Immunization Program in Government of India. And we successed in many of the areas, but only up to 60 to 70% children were immunized even after the outbreak. The 30 to 40% children still we missed. and they are not ready to get their children vaccinated even after all the mobilization activity. So that is my concern and the challenge which I am facing, that after many efforts, after involving the community leaders, even after having the special immunization weeks in my country, these certain people are there who are not ready to get their children vaccinated at any cost. So I am associated with TGLF also since 3 years, and I have continuously been listening to these sessions, and demand creation issue is always there. So at the local level, I have been listening that everybody is involving the community leader or religious leaders. But what we have done at the global level for this situation, and have we analyzed the data for all the countries, but that there is a same population which refuse vaccine every time, or is it a different situation every time? So I need certain means light on that topic, and that's from my side. That in most of the cases we are able to control the outbreaks, but still there is a lot of scope of improvement for the coverage of the measles containing vaccine, so that there will be no outbreak in the future.
Thank you very much indeed, Isha Goyal. So we're going to go to Laura Shimp at some point for feedback, but let's now, and a very clear description of the challenges that you face. Charlotte, who shall we hear from next about this topic of measles outbreaks? We're just getting into it. And Laura says, let's see, for this session on measles, she'd love to hear examples from participants on how you are ensuring that individuals have a record of both doses of measles vaccines that they've received. Often vaccination cards are not emphasized or made available long-term, particularly for second dose. Measles campaigns also have not often given cards to those vaccinated. So we'd love to hear if you have specific examples about that. Otherwise, back to you, Charlotte. Who shall we hear from next?
Yes, Reda, I was inviting Caroline Akoshile to speak, to share experience, because we already received that, but we had some two hands that I'm also inviting to unmute.
All right.
So,
all right, and that is Joseph Abubakar Koloko. Mudassir Abdullahi is the first one to unmute. And again, for our guests of honor, please be ready. You've been invited to our Zoom studio in order to speak. So please be ready if we call on you to share. Mudassir Abdullahi, please do introduce yourself and tell us what you did to respond to a measles outbreak. Again, this is not about expressing an opinion on the topic or discussing theory or generalities. This is specifically about things you have done or carried out. Mudassir, tell us about, first of all, who you are and what you do.
Hello.
Yes.
I work with Kano State Hospital Management Board, Nigeria. I'm a member of State Routine Immunization Coordination Center. Measles is one of the diseases that are very common in our country, because for one reason or the other, mothers don't usually access the vaccination sometimes due to one reason or the other. But whenever
Mudassir Abdullahi, when you say that, is that based on your personal experience? Are you a vaccinator engaging with their caregivers, or how do you know that? Or why do you think that mothers do not?
Mothers, they start the vaccination, they come for BCG, Penta 1, Penta 2, they have.
I'm asking how you know that.
Through our activities,
okay,
when we are reviewing the data.
I see, but does
in my count,
yeah. So the data may show you that there are missed vaccination for measles, but how does it tell you that about caregivers' attitudes and behaviors?
Well, I can't tell you. The network is fluctuating. It's not stable. Hello?
Yes, no, we hear you loud and clear. So what have you actually done or carried out to respond to a measles outbreak?
What we did to map out the settlement where the cases come, and a response team was deployed there to assess the status of the immunization of the children. Through that, we came to understand that most of them were missed their measles vaccinations. So as a result of that, an engagement was conducted with the caregivers where an awareness was raised, and most of the children that were not infected there, and then a vaccination team also set in and ensure that all the children that were not infected were vaccinated, and advice, a kind of health education was given to the mothers in order to see that when they have the first dose of measles vaccination at 9 months, they also come back to the facility to have a second dose of the measles at 15 months. As a result of that, most of those settlements that reported the outbreak in the previous year, there was not such cases in those areas.
All right, thank you very much, Mudassir Abdullahi. All right, let's now go to, I see again in our Zoom studio, and we apologize. We appreciate actually that so many people take the time to respond, to share their experience. Again, we'll be honoring this by publishing a publication dedicated to the experiences that you shared. For now, Charlotte, who shall we hear from next after Mudassir Abdullahi?
I see
Deepanjali.
Dr. Bala and Deepanjali. Yeah, Reda.
All right, let's go to Deepanjali Shretha. Apologies for mispronouncing your name. Deepanjali, a warm welcome to you. Tell us who you are, what you do, and then again, we're interested in your actual experience, what you did to respond to a measles outbreak, as you can see. And we did ask even more specific questions around vaccine wastage, around the specifics of responding to an outbreak, on using data in measles outbreak response, improving second dose coverage, or integrated health campaigns. Tell us, first introduce yourself, and then tell us what is this experience that you would like to share.
Good afternoon, Reda, and everyone who has attended this function. I would like to thank, I'm Deepanjali Shrestha from Uganda. I am originally from Nepal. I have experience of measles outbreak. So what would have been better is that we should have a training for preparedness plan for the vaccination for measles. And if we have training for preparedness to overcome for the outbreak, then it would be better. And for the improvement. For the improvement, what I have done is we had a meeting for the plan to organize the administration of the vaccine, and then we plan to procure vaccines which are required for the beneficiaries, and supplies, and storing and maintaining cold chain facilities before starting the administration, and then appointing skillful nurses and preparing more vaccine administration stations, what was done at the time of measles outbreak from myself. And then the challenging thing what I faced and what my team faced is vaccine availability according to the demand of the vaccine. So we are not able to receive the vaccines on time, so we have to postpone for the vaccination program, and then again we have to call them, and it took a lot of pressure for all the team. So the most challenging thing is availability of the vaccine. And another thing is because of not receiving the vaccination card, we have to give the vaccines to all those who has not received from the government side. Thank you.
Thank you very much indeed, Deepanjali. A very clear description of your experience, and very specifically on what you could have done better, what's been most helpful, and what are the challenges that you face now. Charlotte, is it Dr. Bala Ganesakumar who is next?
Yeah.
Yes.
Yeah.
Okay, wonderful.
Yeah, I'm.
Yep.
Yeah, thank you, Reda, and thank you, Charlotte. I'm Dr. Bala Ganesh Kumar, Surveillance Medical Officer, WHO from India, and the southern part of India, that is South Province of India, Kanyakumari district. Recently, in the July, first week of July, I had a call from one of the very high priority institution, a medical college, nearby medical college. A pediatrician called me and he told me about there's one case of fever with rash in my hospital admitted. And the sibling of the child also had the same history 10 days back. So he notified that case to me, and as being a technical expert on this, I immediately asked them to take the appropriate sample. There was only within 7 days of onset of rash, so I asked them to confirm the diagnosis, to take the samples, both virological and serological samples, and samples were sent to the WHO authorized lab for confirmation. At the same time, I informed the same to the local health authorities to form the epidemic response team, and at the district level, at the block level, taluka level, they formed the epidemic response team was created, and myself being a member of that, I trained all those people who are going to do that field activity regarding how should they approach that type of query suspected outbreak in that place. And we trained all of them, and we started our initial house-to-house survey. The child is being 10 years old, so we started with the house-to-house survey, as well as the same time we had the survey at the child was studying which school. Also, we did the same survey, and we had take up the line list of all the cases who had the history of line list, all the history of fever with rash for the past 90 days, and we created the line list. And among them, we took them samples for around 20, whoever had the fever with rashes for the last 28 days, we took the samples, appropriate samples for recent 7 days cases, we took the virological and serological, and more than 7 days to 28 days cases, we took only the serological samples, and the same appropriate samples were sent to the authorized lab also. Then what we did is we analyzed, enumerated all the below less than 5 years children in that households and that schools, and we ensured their vaccination status, whether they have been vaccinated with MR2 doses or whether they have missed any of the single doses. We ensured it. At the same time, we are all the fever with the rashes cases, we give prophylactic vitamin A also. We have 2 doses we gave them, and then whomever we identified those children who are not vaccinated or under-immunized or who have the immunity gap. Those children, for them, we conducted a special catch-up campaign to cover that immunity gap. And after that also, we kept that villages under vigil for the coming 90 days. So my problem here is, if we are going to take the line listing of difficulty, what I felt is, if you take for the history of fever with rashes for the last 90 days, many of the people have had the history, but many of the people are not even there itself. They have migrated, they have for their work travel, they have traveled to some other, not migrated, they have traveled to some other places. So whether we should track them also because they have traveled to many places. We are tracking the viral transmission among this community, and we are tracking the travel details of the positive cases only, but all the other cases we have missed. They had more than 50 days, 60 days, 70 days before they had the fever with the rashes cases, they have traveled to some other places. So how to track them also? Is there any protocol regarding that? That also I want to know about that. Thank you. This is my experience regarding measles outbreak investigation in my area. Thank you all. Thank you.
Thank you very much indeed, Dr. Bala. Next, we'll go to Caroline Akosile, and then we'll turn to our guides on the side. I realize it makes things more difficult for the guides to have many different stories. Each one would warrant an extended discussion. But remember that this session is followed by networking. So if you'd like to follow up with individual meetings to go further, we hope to leave you thirsting for more. Caroline Akosile, we have... Yes. You shared from Sokoto State, Nigeria, a story about partnering with stakeholders to improve the uptake of measles vaccines in the communities. We'd love to hear it directly from you. Go ahead, Caroline.
All right. Good afternoon, good evening, and morning, everyone. My name is Caroline Akosile. I'm retired. I worked for UNICEF for 20 years, and I've had a lot of experiences on vaccination, especially measles vaccination. And basically, I would say what's most important that I learned or that I experienced on the field, it's the preparedness and the actual response. We needed to prepare, and I worked as a communication for development specialist. So we needed to really talk to the communities on how important the measles vaccine is. And then when we got there, we needed to really work with the stakeholders, like the policymakers, the community leaders, and so on. And then work also with our logistics people to give the children the vaccines during that time.
So
now,
Caroline, I'm going to ask you a question already. When you say we worked with the stakeholders from policymakers to caregivers, that's very general. It doesn't tell me what you actually did to do this work. Can you give me an example of something that you did, perhaps for the first time in this context, because that you had not done before? Can you think of an example like that, or just illustrate what you mean by working with stakeholders?
We worked with them in the sense that we had meetings with them, sensitization meetings with the stakeholders. We had the meetings, and especially also with like the heads of communities. And then we also had some house-to-house talk with the parents, with the caregivers, to explain to them why why we were having the measles campaign at that time. So we needed to tell them that they needed to immunize their children against measles. So those were the type of meetings that we had, or activities that we had with the stakeholders. So because you cannot achieve this alone, you needed some other people to work with you. Right. So, and then what we will have done differently if I was on the field now, which really I'm still on the field, we will have had some maybe outreaches, because now when I'm on the field now, I find out that children who came for MC1, not all of them are coming for MC2. Looking at the registers at the health centers, we needed to have a line listing of the children who are supposed to come, and then maybe go to their houses and make sure that they come for the MC2. And then what are the most difficult challenges that people face on the field now is, I would say, funding. Yes, because they need to go to the field, they need to go to all those areas, communities, to make sure that these parents bring their children for the MC2 especially. So these are my experiences on the field. So we need to prepare, we need to also respond at the right time to make sure that the children get the measles vaccine. And then when they're having campaign like a catch-up and so on, especially in Nigeria, it's not all the states that are involved. They do it in batches. So some states were not involved, and there is a cohort of children who will be left out in those states. So we need to work more with those communities in those states to make sure that the vaccines are available, the children are given the vaccines, and then the workers too are given the enabling environment and the enablement to go and give them the vaccines, and also fish the children out to give them the vaccines.
Thank you very much indeed.
Do you have another question for me, Reda?
Let's find out. So I'd like to actually turn to our guides on the side. So this time I'm going to start with Dr. François Gass, and to ask him for his 3 main takeaways from the discussions so far. So either comments that he'd like to highlight, specific feedback, or questions that he would want to ask if we had the time to take the discussion further. François, if you are able to unmute at this point. Otherwise, let's go to Laura with the same challenging ask. And Laura, there's a lot of complexity to unravel. Can you help us unravel this discussion and go away with 3 takeaways? Your top really points that you feel are really important for everyone to hear, that is likely to be helpful to the practitioners who've been sharing their experiences.
Yes, thanks so much. Thanks for the contributions, and thanks for the comments in the chat as well. Sorry, I'm not able to respond to every one of them. because they come in fast.
Right.
But very important. Three key things that I think we've heard. One is using data to really help us also identify where we have missed infants or younger children who may have received 1 dose of measles but not 2 doses of measles. So how do we really look at the data available, such as in registers or from cards and other things, to really be able to identify those who need the vaccine, and then encourage not only that the community members, religious leaders, and others encourage them to come back for services, but that the health workers welcome them back. And particularly for measles, similar to what we saw for COVID, it's so infectious. If you are exposed and you're not vaccinated, you will most likely get sick. So it's important to really help emphasize the importance of those 2 doses of measles protection and be able to help health workers provide that service as well. Some people noted the issues with distances for vaccination sites, or, we know we have this issue with 5-dose and 10-dose measles vaccines where health workers sometimes don't want to open the vial if there's only 1 or 2 people. So really working with the health system also to address these problems, to better communicate how to get, not to turn people away. What are the best way to organize these services so that we get people vaccinated, don't turn them away for these various reasons. And then I think being able, like people have described as a third thing, to take, not when we have an outbreak and we do campaigns, that campaign shouldn't just stop the day we're doing vaccination. We need to really insist with the vaccination teams, with those who are helping provide resources, that we need to follow up by using data to track where we've missed infants or where we need to find those that may not have come during the campaign. So really not just planning for a 1 week, but planning for a 4 week, so that you also follow up with those communities that have been missed and can help the health workers continue to provide that service, not just during that campaign day. Thanks so much. Great contributions.
Thank you, Laura. Now, we do have Tongwa Gulit Nkani, who's asked, he says, I'm a guest of honor and I haven't been able to speak. So perhaps, Charlotte, we can make an exception. We did try to reach to Tongwa earlier to hear from him. He'll have to unmute, of course, and is not done so yet. All right. So okay, I think this is what happened last time. Yes.
We also had Kamran Khan from Pakistan, who was already unmuted, one of the contributors and also a guest of honor.
Yes.
So had his contribution experience shared. I think it was about vaccine wastage.
All right. And for Tongwa, we're very sorry. And for you and other guests of honor who did not get to speak, in this case, it does seem to be a technical problem on your side. Kamran Khan, you'll be our last speaker, as we do have one more topic in this plenary before we shift to 0-dose children in urban settings. Kamran Khan, what would you like to share about what you did to respond to a measles outbreak?
Yes, thank you. My message will be very, very short. My name is Dr. Kamran Khan from Pakistan. I have worked in immunization program as a district communication officer. I want to share about the nationwide campaign launch in 2021, in which I was working as in one of the district as in District Charsadda in Khyber Pakhtunkhwa as a district communication officer. Just 3 things I want to share which have a very good impact on our campaign. Before starting a campaign, apart from micro planning, training, and other type of activity, we have given special focus to the social mobilization. Like one thing we have done, the advocacy, we have vaccinated the children of policy maker in front of media, and then we send those pictures on medias for mass awareness that the policy makers are vaccinating their kids, so to build community trust on vaccination. Number 2, is the age bracket for this nationwide campaign was from 9 months to 15 years. So our 70% target was in school. So we have properly mapped all the school. We have done awareness session in the school with teacher and student, and we also send a consent form from school to the parent. And those parents who were not willing to get vaccinate their children, situation, we call them to the school, which we directly meet them and done a session and try to convince them. Majority of them were convinced, and we vaccinated more than 95% children in that campaign. So this was my some few better planning, or you can say a better some lesson learned. Apart from this, we have faced AFI, adverse event following immunization, and when it goes on media, so it also affect our campaign. For this, we have already mapped the media channel, engaged them, and we have proper media cell. Before sending any news on the media, it was properly filtered, it was properly corrected, and then shared on the media. Thank you.
Thank you very much indeed, Kamran Khan. Lots of great comments and discussion dialogue going on in the chat in our Zoom studio, but also, all right, some of you are still stuck on YouTube. Please check the emails that you received. There's also lively discussion here on the main stage of the conference platform. Now, we invite you, remember, this is only the beginning of a dialogue. Teach to Reach is an ongoing, continuous learning conversation. Next, you'll have to make a decision if you'd like to go and network. And this is how networking works. You just click on join and you'll be connected to someone else. I'm not going to do it now in order to not to break the flow. And also because I want to share probably the most important call that we've ever made in a Teach to Reach session. And that is the second time only that we have actually launched a call to join the movement for Immunization Agenda 2030. The first time was on the 7th of March. Over 6,000 health professionals from 110 countries committed to contribute to a global movement for Immunization Agenda 2030. What we said at the time was that your commitment can make a difference for children and their families in your country, and that you matter because you are the key to leading the change needed to actually achieve the goals of IA 2030. At the time, over 6,000 of you signed and made a commitment to the Scholar Pledge to work for a world where everyone, everywhere, fully benefits from vaccines to improve health and well-being. Now, 3 weeks ago, we launched a second call inviting those who had not yet joined to do so. And I'm pleased to say that an additional 1,000 participants have joined just in the last 3 weeks. We're close to 1,000. We got close to this 1,000 mark. And what's most amazing is that what we're seeing is a year and a half after the launch of this movement, we're sharing a new set of case studies documenting implementation, documenting impact, vaccination coverage, as well as many other factors and considerations that matter on the ground for immunization staff. So you'll be learning very soon, and all Teach to Reach participants will be receiving these about improving immunization in Zango Ward, Kano State, Nigeria, about improving malaria and COVID-19 vaccination coverage in Kintampo Municipal District in Ghana, going from hesitancy to advocacy in Nigeria, reducing the dropout rates in Burkina Faso, multiple innovations to improve coverage in Ghana, reaching vulnerable displaced populations in Burkina Faso, negotiating access in disputed and volatile areas, and data for action, how Bileme and Binkar in Cameroon boosted district-level MR2 coverage in Cameroon. Now, this is just a few of the dozens of case studies that are in preparation, documenting impact on an unprecedented scale through a digital connected network of immunization leaders from all levels of the health system. We're inviting you today to become part of this amazing story. You'll be receiving, after Teach to Reach, the call to join the movement for Immunization Agenda 2030. If you have not done so, this is your chance to now join the movement, reaching over 60,000 health practitioners worldwide, with around 20,000 who've been working actively within the movement. You can be committed to the goals and then make decisions about how involved you actually want to be. Now, because we spent more time than anticipated, we were going to ask movement leaders to speak up, and so you could hear directly from them. But we are out of time and need to prepare for the plenary session with UNICEF. We have an incredible session planned. Perhaps if there is, I'm going to lower all hands, if there is one movement leader from IA 2030 who'd like to share very briefly, well, we should have time for that at least before we go into the discussion on reaching zero-dose children in urban settings. Let's see if we can at least hear from one person that is a point of Teach to Reach. Kingsley Niniere, indeed, the floor is yours. Would love to hear from you. What is your reflection over a year after joining the movement for Immunization Agenda 2030? And what have you learned and what difference has it made to be part of this movement? All right, Kingsley, your microphone is unmuted, but we're unable to hear you.
Thank you, Reda.
Oh, yes. Okay.
Giving me the message.
Yes, please go ahead.
I'm Kingsley Kofininier. I work with Community Youth Development Foundation, a non-governmental organization based in Ghana, specifically in Tampo in the Bono East region. Since I've joined IA 2030, somewhere in March last year, the IA 2030 has actually built my capacity so much with regards to immunization, specifically how to identify zero-dose children and missed opportunity children within the community. We were taking through responsive feedback, how to identify stakeholders within the community to help us catch up with these zero-dose children and the missed opportunity. And then how to also identify volunteers who are actually willing and committed in identifying zero-dose children and the missed opportunity children within their community so that those children can be vaccinated. And when it happens, so we were so happy that being part of the IA 2030 has helped me to reach less privileged children or vulnerable children that were not having opportunity that we have gotten that. I was so grateful. And coupled with that, those days, even developing my action plan, it wasn't easy for me, but the key area of focus and the strategic priority has helped me identify my challenge, and then have been able to prioritize it and have gone by that particular action plan. And in fact, it has helped me to identify some of the COVID-19 people who were hesitant to COVID-19 vaccines. And those people too, most of them were vaccinated. In fact, if I say IA 2030 hasn't helped me, then it's a lie. It has helped me so much, build my capacity. It has helped me so much to reach zero-dose children and miss opportunity.
Thank you very much indeed, Kingsley Niniere from Kintampo North Municipal District in Ghana, working for an NGO, but a leader in the movement for Immunization Agenda 2030, working side by side with many health workers from government. Now, before we kick off the session with UNICEF, we're going to be doing a little bit of housekeeping. We're very excited about this session. It's generated a lot of enthusiasm. I do have a duty to point out that there are alternatives to this plenary session that are well worth attending. So the first one I'd like to point out is let me see if I can make this window a little bit bigger. Is a session with a Gavi Zero-Dose Learning Hub and really focusing on challenges and opportunities for improving equity and coverage among zero-dose and under-immunized children in 4 countries. So if you'd like to join that session, we're going to give you the exact link. And I see the session is already underway. So in order to join this session, let me just put together the link. You will have to leave, if you are amongst our guests of honor, you'll have to leave the session. Let me see. Let me just, so let me share the link here. So if you want to meet the Gavi Zero-Dose Learning Hub and you are in our Zoom studio, you're going to have to leave the Zoom studio. You can always come back All right. If you are where you should be, where most participants are, which is in the Teach to Reach Connect 9 platform, then you go to sessions, and here you will see there is a Zero Dose Learning Hub session. You click there, and that will take you straight into the session. You'll be able to chat. Now, the team may invite you into the panel, but essentially you'll have to listen and then share your comments in writing. I believe there is also a Q&A. So that is one option that you have available. The other option is to learn more about the research into the impact and the sustainability of the movement for immunization agenda that I have just mentioned. And you can see that session is underway as well. So if you'd like to join that session, let me get you the link as well, just so we can, and let me see if that is, yes. So in order to join the IA 2030 movement session, if you'd like to learn more about this research on the impact and sustainability of the movement, these are the links. So you should be able to, I'm only sharing this with the folks in the Zoom studio because you haven't necessarily been in Hopin, and that is what we're encouraging you to do. So we're now going into a 58-minute session with our friends, colleagues from UNICEF, and we're going to kick that off properly. We're going to do it with a little bit of music. Again, Charlotte, if you could share those links and double check that they work, I'd appreciate it. But Charlotte herself may have, let me see. Right. All right, here we go. So we're going to explore together reaching zero-dose children in urban settings. And again, we start with a very simple prompt: share a success story, a lesson learned, or a challenge. Now, as framing for this, 42% of members of the IA 2030 movement work with the urban poor. That's almost half. So we know that in a way we were confused because some of the experiences that you shared did not explicitly reference the urban context, but then we realized it's because that is your daily reality. So you're not going to point out what you live with every day. What we're interested is in having you tell us about a specific situation and what you did in response to it. We're joined now by 3 guides on the side from UNICEF. You've already met, if you've been in plenary with us, you've already met Deepa Pokharel, who leads the demand team at UNICEF HQ, Charles Kakaire, a demand specialist, and Ibrahim Dadari, who's the focal point for Zero Dose in urban settings. They're going to be introducing themselves when they give their first feedback. As always, we're going to kick off by asking you to share your experience, and we're going to do that. Let me see, we should be able to find, so please raise your hand. We've lowered all the hands, and we're interested specifically in the experiences that that you have shared ahead of Teach to Reach. If you are amongst our, amongst our guests of honor who've been invited to the Zoom studio, we've invited you specifically for that reason. So I see Hamida Mohamed Yaldou will be our first speaker. Hamida, I hope that you are ready to speak. And let's see. All right. I'm going to start by sharing Hamida's story, and that is mothers that couldn't immunize according to the schedule are being educated depending on what causes them not to follow their immunization schedule. So you're a nurse working for the Ministry of Health in Nigeria in a health facility. Hamida, would love to hear from you, asking you to unmute. And it's okay. It can be confusing. If you're on your phone, you'll need to swipe with your finger to find the button through which you can unmute. All right. Looks like if you'd like to share on this topic. Okay, I had missed that there are around 10 raised hands. Let's see. Let's go to, and again, we're looking specifically for contributions on Zero Dose in urban context. So if you work in a remote rural area, it is likely to be very interesting, but that is not the specific topic that we are dealing with today. So let's go to Obatavwe Ukoba. Obatavwe, are you able to unmute? You have your hand raised. Oh, sorry, I think I accidentally muted you again. Please unmute again. All right, and this is part and parcel of learning, defying distance to learn together. Obatavwe, a warm welcome to you.
Good afternoon, everyone. Actually, I'm Dr. Felicity. I had to use my friend's system because I had an issue connecting with mine.
All right, no problem. Do introduce yourself then, Felicity.
Dr. Felicity Odo.
Yes.
I shared an experience, actually. I work with the teaching hospital, Delta State University Teaching Hospital, Ogara, located in Delta State, Nigeria. And in our infant and child welfare clinic, we're faced with the challenge of the mothers holding on to some traditional practices with regards to immunization. They believe immunization is harmful, hence they can't immunize their children. Some of them believe when they immunize their children, they are prone to a lot of illnesses and diseases, considering how remote the area is. However, it led to a lot of nutritional deficiencies that most of these children tend to come down with malnutrition. The data we have with us in the clinic running through May to August, we had a total number of 10 malnourished children, even though they are currently on plumpy notes and they are being managed. And this challenge really drew our concern. So what we had to do was we had to kind of create more awareness, health education, and then we had to go down to these communities because most of all these community members, they are more of traders and farmers. So they are not aware, they are not exposed. So we had to have a kind of community awareness. And with that, it has really helped us go a long way. And we have more children being immunized. Thank you.
Thank you, Felicity. Can you clarify for us, is this in an urban setting? Where is this? Can you tell us more about where this is happening?
Yes, Ogara in Delta State.
Okay, of course, that is my ignorance of Nigerian
Nigeria.
geography.
Yes, in Nigeria.
Yes. Thank you. Right. So, okay, so can you tell us, what did you learn from this experience?
Yeah, what I learned from this experience is most people are not informed. And you know, when you are not informed, you are deformed. And it created an avenue for me to always give out information at any point in time, irrespective of where I find myself. Most of all these mothers are not educated. So I had to go a long way to reach out to most of the community leaders that speak in their dialects to help me communicate with them, thereby creating a very good awareness to enhance our immunization and community participation.
So, Felicity, that is the learning. My next question for you is, how many previously unvaccinated children did you vaccinate through the experience, the effort that you just described?
I think about 10 of them.
Okay.
About 10 of them, yes.
Yep.
The first one we vaccinated, in fact, he came in, the issue the mother had was that the first child, she after the BCG, she claimed, in quotes, that the baby became very sick, became jaundiced, in fact, had distended abdomen. And for that reason, she refused vaccinating or immunizing other children. So we had to pick up that one when the baby was already a year, and we now started vaccination. So that's the first baby we had.
Wonderful. Thank you, Felicity. All right, let's go to our next speaker from in our Zoom studio. So we will go to, let's see, Nietzsche Etienne Kemo. Now, Nietzsche, I know you wanted to speak about measles response. Here, we hope you've also contributed on the topic of zero dose. Could you introduce yourself and confirm that you are indeed ready to speak, to share a success story, a lesson learned, or challenge around reaching zero dose children in urban settings? Again, it's not about sharing your opinion or your general considerations, but really something you actually did and carried out.
Yeah, good afternoon in the studio.
Yes,
can you hear me?
Yes, we hear you loud and clear. Do introduce yourself and confirm that you're ready to share a zero dose experience.
Yes, my name is Chi Etienne Kimo. I'm a public health specialist. I'm chatting from Bamenda, Cameroon. I'm very ready to share my zero dose information.
So please tell us about a specific situation in which you were confronted with having to reach zero-dose children in an urban setting, and tell us what you did in response to that situation. First, let us know what was the situation that you were confronted with.
Yeah, for a start, I'm not actually in the vaccination train, but since I'm a community health worker, from time to time, I always volunteer to work with the vaccination train. So I've come across many cases where zero-dose students they miss out on the vaccination train, the vaccination campaign.
Can you tell us about one of those situations, one of those cases? When did it happen? Where and what did you do? That's what we're very specific story that we're interested in rather than generalities.
Yes, it happened just last August.
Okay.
It happened last August in Bamenda, Cameroon, when I volunteered to work with during the measles vaccination campaign. Yes, I get to understand that many mothers were not turning out for the vaccination campaign. So I had to find out from my community why the reason why they are not turning out. So I learned from most of the mothers that they were not aware of the vaccination campaign. So that's why they were unable to turn out. So most of them, they instead went back to the farm. So I had to create the awareness. I have to get to the director of our health center. So I spoke with her and tried to make her know that they were supposed to go into the community to educate the mothers about the upcoming event of the campaign. So that's what I did.
Okay, thank you. All right, so we'd like to understand better, but in order to do that, for both Felicity and Chietienne Kemo, I'm going to now turn to our guides on the side. I've seen, yes, so I suggest we start with Ibrahim Dadari, who's joining us as a guide on the side for the first time. A warm welcome to you. Do you have follow-up questions? Things you would need to know in order to understand the situation described by Felicity from Nigeria or Etienne from Cameroon? What else would you like to know before we get into your advice and guidance in response to the situations they've described?
Thank you, Rita. Thank you, colleagues. Good morning, afternoon. Here, Dr. Ibrahim Dadari here, immunization specialist with UNICEF and focal point for urban. Very interesting experiences shared by Felicity and from Bamenda. So one of the things we know is that some of the examples they're sharing, like Delta University example, as she said, is in the urban settings. What specifically did they do, particularly to reach out to children who didn't show up at the facility? Because we know some of the issues faced by urban include an underestimation of the target population, a lot of mobile population, a lot of migration inwards. So usually what you see at the facility or at the clinic is just a tip of the iceberg. So you need to reach out more broadly, expand your microplan to be able to catch children who originally probably were not there last year, but they say they've moved from either as part of displacement or deliberate migration to the urban center. Thank you.
Thank you very much indeed. So let's go now to Felicity, who I believe is using the an account. Perhaps, Felicity, you had trouble. So I'm asking Obatwe Ukoba to unmute in order to answer that question, but we know that's Felicity. And then let's go to Etienne. Can you tell us more in response to Ibrahim Dadari's question? what exactly did you do to reach out to children? So this was in the context of a campaign. You see caregivers are not coming. What do you then do in that campaign to follow up, to figure out how many children there are, where they are, what the reasons for why they're not yet vaccinated? Can you give us more of the specifics of what you actually did in response to this situation?
Yes, as a community health worker, I've been working in the community for a very long time, so I have that trust. My community members, they have trust in me. So I had earlier created a WhatsApp group where I send information concerning vaccination. If there is an upcoming vaccination, I send out the information to them. I let them know the time and where they can go for the vaccination campaign. So from time to time, I always go from door to door to contact, because in my community in Kwenya, in Bamenda, we have community mobilizers. The community mobilizer, their job is to go from door to door to inform. Maybe one day to the vaccination campaign, they go from door to door to inform the mothers about the vaccination. So what I do as a community health worker, I go to the community, I meet the community mobilizers. We both go to the communities, we educate the mothers about the importance of the vaccine, educate the mothers about the time. They should not miss out. They should not miss out on the vaccination. They should make sure to bring their children for vaccination.
Thank you, Etienne. Now we have Udoji Danjuma Makoshi, who has a hand raised. So I don't know if that is to share an experience, or if Udoji has follow-up questions or comments in response to the two experiences shared so far. Udoji, could you introduce yourself and tell us if you want to share your own success story, lesson learned, or challenge with respect to reaching zero-dose children in urban settings, or if you'd like to make a comment?
Yes, Dr. Reda, thank you very much. And Dari, thank you for that input. I stand as Danjuma Makoshi from Zamfara State, Nigeria. Actually, I would like to give my success story concerning how we're able to reach zero-dose children in urban setting in Gusau and some of the major local governments in Zamfara State. One of the challenges that we have is the attitude of health workers, as well as the security challenges that we are having, that we are not able to reach zero dose, in which, based on the surveys that we have, Zamfara State stands one of the states that have high number of zero dose children. So we made different strategies, but from the last intensification that we have, that was around May. The other intensification, we are able to develop strategies that we are able to track and also reach out to the zero dose. One of it is that we had a very robust planning where we developed a template where we earmark where are those zero doses can be found in urban setting by having desk review of our RI data. We look through the previous data that we have, and by that we are able to have settlements and places that have high number of zero dose. So after we are able to fish out the settlements, we also develop an ODK form that is using the geospatial analysis, where each supervisor, each team that have they go out for vaccination, the supervisor will record the children immunized. Then we have the position of that team, where they have worked and when they start and when they end their work. And by doing that, we're able to earmark from day 1 to day 3. We know specifically where teams work and where teams they are not able to reach. And we're able to bring statements that we are not reach. And we are able to send additional teams to go out and ensure that those settlements were reached, so that we can reduce the zero dose in that zero dose children in those settlements And by doing that, we are able to achieve where we have high number of children with IPV2, high number of children with measles containing vaccine 2, and the coverage was so high that even the National Primary Health Care Development Agency acknowledged Zamfara State for the reduction of 0 dose in the state. And that, I think, is one of the lessons that we learned, that using geospatial approach to our strategy, it yielded a better impact to our campaign. Thank you, and over.
Thank you, Udoji. Can you tell us a little bit more about what you measured and what the results were in terms of the number of 0-dose children that you were able to identify and reach and actually vaccinate?
Yes, actually, the data is not in my front here, but I think in my next listen, I would like to share it with you. But we have a drastic reduction in 0-dose and high coverage of other indicators.
All right, thank you. Thank you, Udoji. All right, let's go now to a second guide on the side, Charles Kakere. Charles, a warm welcome to you. This is not your first time as a guide on the side. You've heard an additional story. How would you like to, would you like to share a comment, feedback for about these experiences, or do you have follow-up questions? I'm asking you to unmute. Yes.
Thanks, Reda. Good afternoon, good evening, colleagues. It might not be particularly responding to what the previous contributor shared, but just to be able to, reflect on some of the challenges, from a communication or a demand side that come with urban. The fact that, urban is very cosmopolitan, these people who come from different places, speaking different languages, different culture, all that has a lot of influence in terms of how we develop a message, in terms of how we engage, but also in terms of, the different feedback mechanisms that we have. So in whatever we do, when trying to mobilize these communities for immunization, I think it's important that we, pay a bit more attention to the nuances that come with, with the different groups that we have within an urban context. That also directly links to a number of other things. The media consumption, that comes with people within the urban settings, the influencers. We know that within urban settings, there tends to be, those influencers who might not be our usual suspects that we normally think about. So how do we harness those, that are key influencers within the given locality to ensure that, we work with them as allies to help, to help in, raise the demand for immunization. Also linked to that is misinformation, which we also see quite more within urban settings. How do we handle that? Just ensuring that we're able to provide the right information amidst the different information sources that people have. We know that the concept of sort of citizen journalism, if you like to use that term, within an urban context, is very high, with everybody else acting like an expert, in the piece of information that they provide. So how do we, I think it's important that when we are looking at urban context, it's really important for us to be able to look at the different nuances and context which come with an urban setting, to be able to see how best we can work together to encourage immunization within those settings. Thanks.
Thank you very much indeed, Charles. All right, I have lowered all the hands in our Zoom studio. Please put it up again if you really have a specific success story, lesson learned, or challenge that you would like to share, especially if you are amongst our guests of honor. So let's go to Pam Dauda. Pam Dauda, over to you. We'd love to hear from you. Yes, and you're unmuted. Okay, great. Could you introduce yourself and then tell us, is it a success story, a lesson learned, or challenge that you have to share about zero-dose children in urban settings?
Well, thank you very much. Good afternoon, colleagues. My name is Pam Dauda. I work in Bauchi State. It's just a challenge I want to share, and I want to see how we can move around to be able to take care of those challenges. one of the major things we find out around here, one of the challenges we see, is that in urban settlements, these are environments or areas.
Pam, I'm going to ask you to take a step back, because you're about to share something very general with us. We're interested in a specific situation and what you did in response to it, as opposed to what the sort of what you took away after having been through the experience. Sorry to cut you off, but that is important in terms of sharing experience in the most useful, productive way.
Okay, what I was just trying to say is that I've had an experience in one of the settlements that is urban. And we know that urban settlements are settlements where you have people who are learned. But you will see that a settlement which is just close to the facility, you still find zero-dose children. So I begin to wonder, what is the reason? What has happened that educated, that is one, and also residing close to a facility in a settlement that is not hard to reach nomadic, but still find urban distance. I had a situation like that we were able to interact because we found out that the fact that they are there, they know they are just naturally not interested. So they need to be talked more. So we had a team, went out and talked to them and discussed with them, why is it that the facility is even close to you? The father is educated to an extent, but still their children are not immunized. Sometimes we come to find out that maybe our health workers feel, that's my finding actually then, our health workers felt like, these people are close to us, they come here, they take we see them every day, we talk to them, so there's no problem. But on research, on finding out, we find out that they are not immunized, they are zero dose. But what we did in that particular settlement was that we went back, talked to the people around there, and also talked to the health workers to keep an eye on the closer people who are there in the urban centers, who you think that they know and they are already enlightened to be able to do. We did that and we were able to immunize few of the children that were zero dose around that community. Thank you and over.
Thank you very much indeed, Pam Dauda. A concise and to the point story. Again, we're really asking about the specific situation, and then you can tell us what you learned. That's actually the last question there. Now, Kalu Joy has a hand raised, so let's go to Kalu Joy. And I believe we do have in mind our rules of equity between countries and genders to make sure that that there are people from many different countries that speak. Kalu Joy, please introduce yourself and then tell us about the specific situation involving zero-dose children in urban setting and what you did in response to it.
Okay, thank you, Reda. My name is Kalu Joy Mbal. I'm a lecturer, also a researcher. So I work with a team of researchers who are my students, actually. So let me go straight to the point because of time. So I had this experience with a schoolmate who just put to bed. So I found out that when I went to do a visitation to check on the newborn, so I found out that she hasn't immunized the child for the first time, and the older children that she has too. So when I tried to inquire what happened, she told me that the hospital where she usually put to bed, okay, that they charge very high for immunizations, and that makes her that she's not interested on the immunization, considering the situation of things in Nigeria. That's my country. Okay, so I had to introduce her to a primary health care facility, and that was I told her when the child is 6 weeks that she should inform me so we can go to a primary health care facility, and that she did. So we went there. The child was immunized at a no or low cost. Okay, so she was able to bring other children of hers who haven't had immunization from birth. So that was actually a success story for me, that I was able to identify some zero-dose children and they were immunized. Okay, then the experience I learned from that was I had to go back to my team of students who I usually work with. Okay, so we usually have this community sensitization that we do. We do house to house sometimes, or we do a kind of a community based. Okay, so we have to go to house to let them know that in case you put to bed in a private facility, that's a hospital, that you can come to primary health care where there is vaccine, and that the government gives this vaccine, and there are donors that equally bring this vaccine so that your children can be vaccinated against any form of illness. And since then, there has been a great output so to say, because some of the facilities that we visited, as primary health care, they have been telling us that people have been coming, and you find out that children that were not immunized at the appropriate time, maybe at birth or their 6 weeks, they have such cases, and they've been able to immunize those children. So that's a really success story to me as well. And again, for the HPV, I don't know if I'm allowed to say something on the HPV. Reda, am I?
It's probably close to your heart. So if you can make a concise comment about it, yes, please do.
Yes. Because actually, I think in last 2 years, I voiced out that HPV vaccine wasn't in Southeast, and now by October this year, now they are rolling out the vaccine. So it's equally a huge success story to me, and I really want to say a big thank you to this platform on which my voice was heard. Thank you very much, Reda, and thank you, colleagues.
Thank you very much indeed. Now over to Vishesh Kumar from India, who says he has a success story. So we're looking forward to that. And then we'll go back to the guides on the side. I'm going to ask Deepa Pokharel, who leads the demand team at UNICEF, to take on the most difficult, the most challenging task for a guide on the side, which is to help us gain some perspective. Many different stories, all of them not quite complete. So we'll be going to Deepa, but let's first listen to Vishesh Kumar's success story on reaching zero-dose children in urban settings. Don't forget to introduce
Thank you, Dr.
yourself.
Reda. Thank you very much, and good evening, colleagues. I'm from India. I'm Dr. Vishesh Kumar. I'm working with World Health Organization, Country Office, India. As you know that India was having the largest number of zero dose in the world due to COVID pandemic, and I'm working in an urban setting where population is around 11.2 million. And what we did that we were focusing on the zero children in the entire country, but you can see that the urban setting which I am working was having a population of 11.2 million. And we introduced a system of electronic registration of all the due children up to 5 years of the age. And the urban setting, they planned only for only 0.8 million children they have registered. Then we monitored those children, and we went to the authorities and deployed the nursing students, and more than 1,000 nursing students were deployed in that city. They went house to house and they registered all 0 to 5 year children electronically, and then they were followed up and vaccinated. And we reached around a coverage of around, we reached around 7.6 million population we reached, and we covered almost around 85% of zero dosers in that city. So that I mean that proper head count survey of 0 to 5 year children, going house to house and enumerating those children and mobilizing those children to those session sites, and we place session sites near to the community, and it has increased our coverage. Thank you, Reda. Thank you, and over from my side.
Thank you very much indeed, Vishesh Kumar, and all the other Teach to Reach guests of honor today who shared their experiences ahead of this session and who are sharing live now. I'd like to go now to Deepa from UNICEF, and Deepa, asking you to help us unravel all the many different things that we've heard. We've heard some great advice and guidance from Charles and Ibrahim. What's on your mind? What do you think is most important to highlight and to emphasize at this point for these zero-dose practitioners in the room?
Thank you, Reda, and thank you, colleagues, for really sharing things which are happening on the ground. It's really so much of insight, and really appreciate everybody who shared. So just reflecting on a few things which has come out from the stories across different countries, but also looking at what would probably help colleagues to think about is, we know that urban immunization is very complex. It's not as simple as a rural area where everybody literally knows everyone, so it's easier to track these children. So I think the starting point is, how do we really identify where the zero-dose children are? Because we heard from colleagues that, you know, these are IDPs, these are new people who've come to the urban areas. And if you look at across the board, usually the urban poor settlements are always hard to get. So let's start off thinking, we just heard from India, about how they are using electronic register to just go house to house and then enter it into the system. But not all countries would have the electronic register system started. So let's look at what is available in terms of structures, the primary healthcare structures. Somebody mentioned that, the cost of timing and not knowing that, it can be available free of cost in the primary healthcare is a really interesting one, because a lot of time people may not know about it, So first, to identify where these zero dose children are, let's use the mechanism, whether it's a community health volunteer or it could be an NGO which is supporting the Ministry of Health, the CBOs which are available. We can also mobilize a child-to-child approach to ask them, please find out how many children are there in your own area. So I think that's a start to identify where the people are, and then based on that, whether we enter into the system and then have the community health volunteers and the mobilizers send them reminders if it's a second dose that we're looking at. I really like the idea of working with the nursing students, but many times you would understand that in the urban areas, the pediatrician and the nurses play a big role because they are very trusted source of communication. So often we miss out that we do need to work with this association of pediatric doctors and nursing association, who would then be able to communicate well with the people who come there to make sure that the children are vaccinated and they are taken at the right time to be vaccinated. And the last thing I wanted to say, Rhoda, is taking the services closer to the communities. I think we just heard from India and other colleagues also. How do you make sure that we are taking the services closer to the people rather than actually the other way around, where they have issues of cost and transport and all? Let me stop there.
Thank you very much indeed, Deepa, and fellow guides on the side from UNICEF for this special session on reaching zero-dose children in urban settings. We're asking you to share. It can be a success story, it can be a lesson learned, it can be a challenge, but it needs to be something specific that you actually happened to you, that you were involved with, and we're interested in what you did in response to it. How did it turn out? What did you learn? Those are the questions we're asking. For those of you who are on the main conference platform, here we have a few contributions. Joy Ojugbeli, who says, my challenge till now is that the LGA the local health authority has not been able to get money to meet all the hard to reach areas from the local government. But my achievement, unfortunately, Joy, if I could ask you to, my achievement was that during the OBR1 campaign, we were able to visit all the wards and vaccinated 16 zero-dose children across both LGAs. Concrete examples of what it takes to actually lead change in such a context. We have many, many other comments. I'm sorry we're not going to be able to get to them all because we want to keep listening to your stories and experiences and turn to our guides on the side. So I'm now going to go to, let's see, we have heard from, let's go to Auta Samelia and Najib Ibrahim, who have hands raised. So please, Najib Ibrahim, I'm going to ask you to unmute, as well as Auta. Yes. All right. All right, let's start with Auta Samelia. Can you tell us where you're from, where you work, what you do, and then tell us about the specific situation in which you tried and maybe did reach zero-dose children in an urban setting. Auta Samelia?
Yeah, good afternoon to you all.
All right. Can you introduce yourself, please?
Good afternoon to you all. My name is Auta Samelia, calling from Kaduna State, Jama local government. Can you hear me?
Loud and clear. So tell us, what was the specific situation that involved zero-dose children in an urban setting?
Yeah, the success story so far, the method I adopt to make sure that all the children from zero dose being immunized. From our instance, the parents were not allowing their children to be immunized. What I did first and foremost is to organize a town hall focal group discussion with the parents, and also to tell them the importance of vaccination on their children. Also engage with the... Hello? Can you hear me?
Yes, loud and clear. Please proceed. Occasionally, we have some people who accidentally unmute their microphones. That's what happened. Please go ahead.
Okay. So after being organizing the focal group discussion, telling them the importance of the vaccine to their children, and I also engage on the security aspect. I engage the security apparatus on the importance of securing the community to allow all the zero-dose children coming to get their immunization. That was the first success story. And the physically challenged, those that cannot go because of the distance, I actually have a group discussion with them together with the vaccine officer. So what I did, I put them in a specific strategic places. Then I invite the vaccine officers, and all of them were actually vaccinated. So that was the success story so far for now.
Thank you very much indeed, Auta Semelia. Let's go now to Najib Ibrahim, and then I believe, let me see. Do let me know. Yes, Sabo Maimuna, you'll be next after Najib. As you couldn't find the icon to raise your hand, I'm glad you put a message in the chat, so I've actually done that for you. Najib, over to you. Introduce yourself and then tell us about a specific zero-dose urban setting situation, what you did in response to it.
Well, good afternoon all. I'm Najib Ibrahim. I'm community health practitioner. I'm working with one of the facility here in Kano State of Nigeria. So as I started mentioning in our last session, that was last Friday. Well, for the what we were observed for the zero dose reduce in our immunization data is we have observed that most of the delivered women, out of the 100%, only 60 to 70% are able to bring back their children to immunization. Hello?
Yes, we're listening. Please proceed.
Well, so as we observe that, so we are able to set and discuss with our necessary personnel. So and we have adopted the strategies. The strategies included we have started initiation of tracking of the newborn babies right from the maternity to ensure all the newborn baby have immunized. And then secondly, we ensure that all newborn babies are immunized before being discharged to home. And then we encourage mobilization on importance of immunization, especially during antenatal care for the pregnant mothers. And we develop or initiate an awareness, community awareness. We liaise with the community leaders and all necessary concern for the awareness about the importance of immunizations. So apart from me, this is my little contribution there.
Thank you very much indeed. Now let's turn back to our guides on the side. So let's start with, let's go back to Ibrahim Dadari. And I want to thank all of the Nigerian scholars who've contributed. Nigeria is our largest community of alumni. Nigeria is one of the 4 countries where we have appointed ambassadors for Nigeria. So we appreciate the Nigerian presence. We also want to encourage other countries to contribute to this discussion. But Ibrahim Dadari, can you help us unravel and make sense of what the different experiences shared are telling us? What would be your feedback, guidance, suggestions, maybe even recommendations to the different cases, situations that have been shared?
Thank you, Rita. Thank you, colleagues. I think this is quite exciting, what is being shared from Nigeria to India to Kenya to Uganda. I've seen in the chat, it's really exciting. And it's showing that colleagues are making a lot of efforts to be able to reach the zero-dose children with vaccines in all the settings, which is commendable. And they've shared quite a lot of different perspectives as well. But I think the key thing, what we could make out of this is that one, we need to have a holistic plan, a deliberate strategy. As India mentioned, I know they have the National Urban Health Mission, which was built around the National Rural Health Mission to target children in urban settings, particularly those in urban, peri-urban slums. But also we noted that we have zero-dose children sitting close to the health facilities. Those educated, big houses that understands the value of immunization, as we assume. So that is telling you that we have hard to reach close to the facilities. So when health workers are planning to communicate or to deliver services, they need to be conversant and understand that we shouldn't leave those close to the facility. Don't assume that their children are vaccinated. In fact, I was in Malawi last 2 weeks, and we're talking about the stakeholders were saying probably a lot of them have zero-dose children in their houses, which they neglect because they assume that things will happen automatically. Never assume. But when now looking at mapping the zero-dose children, we know that the urban settings, as described here, is a heterogeneous population. So communication has to be broken into, for those that are educated in the cities, well affluent, the type of communication has to be contextualized. For those coming from rural or migrating, staying in the urban or peri-urban slums, or even those in informal settings, you have to also tailor the communication to their understanding as much as possible. One thing that came out is also the use of technology. Somebody talked about the use of WhatsApp and that has been powerful in a lot of places. Particularly, we know that the penetration of mobile technology and internet in urban settings is relatively higher than rural settings. So you could leverage on that opportunity to try as much as possible to share the message, to create caregiver and health worker groups to be able to disseminate information and try to dispel some of the wrong notions on vaccination that are being shared out there. Somebody also talked about community volunteers, community, and that is fantastic. We know there's a lot of opportunities for volunteerism in the urban settings. Try to leverage them, to use them to communicate. Where you have informal or peri-urban settings with formal community leadership structures. I think we should use that. Well, one point before I forget, I think just to let our colleagues know that yes, somebody was talking about hospital deliveries. Hospital deliveries is just a part of those that actually deliver. So when we are planning, we shouldn't forget that there's probably also an equal amount, particularly in Nigerian context, an equal amount that has not delivered at home. They didn't come to the facility. So when you're planning, don't just look at those that came to the facility, but also think of those that did not come to the facility and see how to try to reach them with vaccines. Over. Thank you, Rida.
Thank you very much indeed, Ibrahim Hadari, Global Lead for Zero Dose in Urban Settings at UNICEF. So Unziku Tolbert will be our next speaker, if Unziku is able to unmute their microphone. We still have many hands raised. Again, we're interested in hearing from as many different countries, as many different situations as possible. Unziku Tolbert, a warm welcome to you.
Thank you, Reda. Are you able to hear me loud and clear?
Loud and clear indeed. Tell us who you are, what you do, and then please share your zero-dose urban setting story.
Yeah, thank you, Reda, and the team in the studio. My name is Unziku Tolbert. I'm from South Sudan. I think the first in the to speak from South Sudan. I work for UNICEF as a health specialist based in one of the states, that is Upper Nile State. Upper Nile State is bordering Sudan, where there is conflict at its peak. I think it's a global news. All of us know. So the town urban setting that I'm talking about here is called Renk. Renk is a location where currently there are over 200,000 population that arrived from Khartoum, Sudan, fleeing conflict. So the case at point is that when these people came from Khartoum to Renk town, because it's an urban setting with good social services, electricity, good water supply, then suddenly we started seeing outbreak of measles. We started seeing cases of measles in Renk hospital. And all what we did is to review the travel history and the data in the registers. We realized these are people who had travel history from Sudan, and they were based in Khartoum. So we had to immediately convene meetings and start planning reactive campaign, and also to ensure that every child is reached, and every household where at least population arriving from Khartoum, where they reach were traced. And also because they are also conducts, so we first of all did a measles reactive campaign, and also we did at several other rounds of campaign. We integrated campaigns were done. So after that, we changed the strategy because the campaign mode is very expensive. We now at the entry point where people go, where they pass from, where the entry point is at the border. We instituted a vaccination site. Every child that enters and in the country now has to, whether a refugee or returnee, has to be vaccinated, so that the cost is a little bit lowered. We do not need to go to the others. And also we made a discovery that, and other than these people who are returning within the township, there are other people who were resident but not vaccinated at all, and they do not have vaccination card. They are not vaccinated. So what we did, and when we asked them, their parents, we did through UNICEF, we have what we call SBC. We did a survey, and the survey found out that most of these families that had these children unvaccinated related their disbelief in power of the vaccines. But we use the radio stations and SMS, bulk SMS approach to reach out on short messaging, and also to host talk shows. And many of those parents who initially did not allow, even during the campaigns, did not allow their children to be vaccinated, were able to accept. And we also use the power of the authority. The local authority also got involved for some of those, because we mapped out where the households where we did not succeed in vaccinating the children. So administrators, the township administration also got involved, and this pushed further. Further, the last line was now in the for the returnees. Those who completely refused were not able to access other supplies, because we realized they needed the food distribution, and they also need the nutrition supplies, BP5 and those ones for their children. So for a child to access this, they have to be vaccinated. So with this multifaceted approach, we managed to reach all the children in Reng town and Reng urban setting, and this has been the success of this intervention. I think we can share it as one of the success story. So allow me to stop here. If you have follow-up questions for me, please go ahead. Thank you, Reda, Saki.
Thank you, Unziku Tolbert. Thank you very much indeed. All right, we have just less than 5 minutes to bring this session to a close. We hope it leaves you thirsting for more. We'll be asking you for your feedback, for your learning, for your reflections after this Teach to Reach 9. We're now going to go back to our guides on the side. Perhaps if Deepa could share her final reflections, thoughts, recommendations, suggestions on these issues. We've had a very rapid overview of many different situations. Again, we count on our guides on the side to help us with the sense making, with unraveling the complexity of the actual daily practice of what people in the field do to get the work of immunization done. Deepa, are you able to unmute to share with us your thoughts and what could you imagine as maybe a next step following a discussion like this? What would be the next set of questions to consider?
Thank you, Reda, and thank you again for the last round of colleagues who shared their experience and success stories from many different contexts. I think I would still want to go back to what I said before, that data is going to be so important to really understand where these children are. Some of the things which just came out in the last round of sharing was that when it's urban immunization, it's very complex and it's very hard to identify. But some of the strategies which prove to work is like taking the immunization site at the borders, the cross borders, and vaccinating as many children as possible. So we might want to think about how do we coordinate and synchronize with the cross borders, because just an example of Sudan and South Sudan, how there is an inflow of people, not just from within the country, but across the borders. So I think that's going to be really, really important to consider as next step when we are planning our SIAs or campaigns. But for the routine immunization, I think just letting people know, because these are going to be people who have just come, there's a lot of mobility, the IDPs, the people may not really know where they are going. So I think that just mobilizing the resources that is already there within the primary healthcare, whether it's community health volunteers or you work with the CSOs. And one thing I was thinking and reflecting on is in many countries, Rotary does quite a lot of work in terms of helping the Ministry of Health, the health facilities, the district health facilities to mobilize and find out where the people are. There are many churches who support, like the Latter-day Saints, who do a wonderful work in supporting the measles campaign, for example. How do we tap into these existing resources moving forward and make sure that our lives become a little bit easier? I think it's the accountability on the health system and the vaccinators and many of health workers like yourselves who do such wonderful jobs in complex setting, which we really appreciate, of course, is there. But how can we add on to the work that you are already doing in the country? So I think data, I would focus, if I was to summarize it, I would say let's look at local data and see who is being missed out and try to look at what are the organization and the systems which can really help us. But also looking at this complex environment, how do we take the services closer to the people, whether it's through the outreach session or through the regular immunization, where we want people to be motivated enough to come and get vaccinated, talking to the mothers, talking to people who are hesitant, whether it's HPV or measles. I think it's very important to listen to communities and plan with them. Thanks so much.
Wonderful. Thank you. Deepa Pokarel, Charles Kakere, and Ibrahim Dadari from UNICEF are our guys on the side today. Thank you so much to all of the leaders, health leaders who shared their experiences in this session. If you did not get to speak today, your full story may be selected for publication in the compendium of experiences shared from Teach to Reach 9. So now let's look at what is coming next. And we have, you can see here at 5 o'clock, we're leaving the boundaries of immunization to explore health professionals on the front lines of climate change. So we're going to be shifting gears a little bit, and we invite all of our guests of honor to stay, because even if this is not your area, this is not what you work on, this is an area that is actually of concern to all of us, and we'll be asking you a very simple question to start. Is climate change a threat to the health of those you serve? Why? And we'll ask you to introduce yourself and also to try to aim for concision. We'll be sharing. This is the follow-up to our 28th of July event. So I want to give everyone a chance to go look at the schedule here. So you can see that at 5 p.m. Geneva, you'll see your own local time. You can join you can stay for this session from Community to Health. You can go to Network, and then at 5:30 at the half hour mark, we'll be discussing the hearing experiences in the fight against female genital schistosomiasis, FGS. So let's kick off this session for climate and health. We'll have to start with some music and a warm welcome And Charlotte Mbu is back with us for this Teach to Reach 9-session Health Impact for Local Communities on the Front Lines of Climate Change. We're going to be now exploring a question that is likely to be critical for everyone working in health, and that is the impact of the change in climate on the health of the community that you serve. On the 28th of July, we held a remarkable event. 4,700 health professionals had registered for this event, including 2,469 francophones. We wanted to check in with you and to again, since the 28th of July, for those of you who participated in that event, to ask you to share where you're at on this question, starting with a very simple question. Do you consider climate change to be a threat to the health of those you serve? So we'll start with Kingsley Niniere, who has a microphone unmuted. Kingsley, first of all, were you there on the 28th of July 2023 event?
Yes, thank you very much for this wonderful opportunity. I'm Kingsley Niniere, working with Community Youth Development Foundation as a community health worker. Yes, climate change is a threat to health in the Kintampo municipality. Why am I saying so? We are currently in the rainy season, and there is severe downpour of rains. And then, as there are downpours of rains, what happened here is that most of the rivers are flooded, and most of the gutters are flooded. And what happened here is that it breeds a lot of mosquitoes, and these mosquitoes bite the community members, and by so doing, it gives them malaria. So by so doing, I can say climate change is actually a threat in the Kintampo municipality.
Thank you, Kingsley. All right. So what you told us, we asked 4,700 people, 1,234 responded with detailed context-specific observations. The first thing we learned is that, and we confirmed, let's say, is that most of you who work at the district or facility level, primarily in smaller communities, tend to be, as health workers, considered by the community as a trusted friend or as part of the family. You can see that's over 80%. And then overall, when we asked you, is climate change a threat to the health of the community that you serve? You can see that most of you, over 600, gave it the highest threat level. And you also personally worry as health workers about climate change. So that's what you told us. That's what 1,234 of you told us. We're here to listen to you now around the same question. And our next speaker will be Ismaila Edego. Ismaila, we'd love to hear from you. Do introduce yourself and tell us, is climate change a threat to the health of those you serve?
Good morning, good afternoon, good evening. Am I audible enough over?
Yes, loud and clear.
Yeah, my name is Ismaila Ibrahim Edego from Kaduna State, Nigeria. I'm an independent immunization consultant. I will say yes, that climate change is a threat to the health of the people around me. The reason being that these rains comes with a lot of flooding, like the last speaker said, and then this affects the farms of these people around. That most of their houses, their farms were flooded with rain, and then because of this, there's a lot of hunger because their farming activities have been affected. And apart from that, the rains, the floods comes to a lot of diseases like cholera and malaria, such that even getting immunization to these people becomes a little bit difficult because they kind of have a two-edged sword where you have to first of all empathize with them regarding the circumstances they find themselves when their farms are flooded. Some of them are having issue of cholera, malaria, and then we have to bring so many interventions in order to ensure that our immunization activities even have a success. So climate change is real and it is around us. And then the best way we can do to help these people is to collaborate with other organizations and agencies that are into climate change so that we can sensitize our people regarding the rains. There may be areas which are kind of flood prone so that we will know how to go about their agricultural activities so that they can mitigate such cases. If not, we are going to have a lot of challenges to overcome in terms of the health of the people on one hand and how to get immunization to them on the other hand. Thank you, and over.
Thank you very much indeed, Ismaila Edego. Now, in thinking about these issues, we're talking about two very complex changes. First of all, are changes in health, and you can see here everything from anxiety, depression, cardiovascular, cerebrovascular diseases, cold-related illnesses, disruption of healthcare infrastructure. You already know many of these as health professionals, and you can see these changes in health. Here, heat-related illness, malnutrition, occupational health hazards, post-traumatic stress disorder, non-vector-borne infectious diseases, vector-borne diseases, skin conditions, waterborne diseases, and so on. So those are the ones you know as infectious disease workers in immunization, or if you don't work in infectious disease, you're still, these are part of your world as a health staff. But now what we're thinking through since the 28th of July is what are the connections between those changes and changes in the environment. And you can see some of the possible changes. It's for you to figure out which ones of these are relevant to your context. Is it a change in weather that has led to an increase in food spoiling pests? Is it drinking water that's become less clean or harder to access? And these are changes in the environment. They may or may not be the result of change in climate, which is much longer term. Flooding, drought, damage to water pipes that affects the water supply, rainfall more or less frequent, the air has become less clean, the ocean is warmer, the sea is encroaching on the land, the sun has become stronger, there have been more frequent big storms, floods, long dry periods, or wildfires. Urban areas are becoming hotter due to less nature to cool them down. Now, if any of these rings a bell, you say, yes, this is happening in my community, you may want to consider this question. Is climate change a threat to the health of those you serve? Dr. Tusime Ramadan, you live in Port Fordal on the border between Uganda and the Democratic Republic of Congo. Please introduce yourself and tell us why do you think climate change is a threat to the health of those you serve?
Thank you, Reda. Are you getting me clearly?
Loud and clear.
This is Dr. Tusime Ramadan from Uganda, a retired medical doctor, working for a community-based organization called Humanitarian Volunteers International. We are an implementing partner for organizations and we do voluntary work. We are working across near the Congo border and outbreaks spill to our country. Climate change has caused problems to very many people we serve. For example, rain season. The rain season now is not timely. And when it rains, floods come, they destroy homes, destroy crops, and they destroy houses. So they affect our work of immunization. The sun has become so hot that even other people get mental disturbance because of the sun, and that also affect the population we work with because of the results of the climate change. Floods, for example, we are under Rwenzori Mountain in Uganda, in Kasese district. So the floods, Kabarula and Kasese district, the floods have swept villages and houses and hospitals. So our work has become difficult because of that. Climate change. I'm the country director of the Volunteers Association, and we work with volunteers. So we are contracted by the government to do immunization, but climate change has done harm to us. Cultivation has become difficult because of the rain sweeping the crops and the heat killing seeds. And so there is hunger. So if there is hunger, our work is not done well. Animals, we are pastoralists and animal keepers in this area. So animals die due to drought, less of food, lack of water, so that it affects the community we work with. So climate change has affected the work we have been doing. Bad water. So when floods come from the mountains, we are under Rwenzori Mountain. So waterborne diseases, many people get sick. So it's a problem to us. Storms, very big storms come with winds and sun, so they affect communities. And lastly, that is the challenge we meet in our work because of climate change. So if there are any other questions, Reda, you can ask me so that I can answer them.
Dr. Tusime Ravadan, no further questions at this stage. Thank you. All right, wonderful to hear these voices, your perspectives, seen from the work that you do. Many of you, but not all, work in immunization. Charlotte, back to you to indicate who shall be the next speaker. I see many women actually who have their microphones activated. We'd love to hear perspectives from both men and women from as many different countries as we can. Who shall be our next speaker, Charlotte?
Thank you, Reda. I'm inviting the women. I see Flora Fonyu. If you can tell us if climate change is a problem for the communities you serve. Okay, Rebecca Bello, you're first to unmute yourself. Over to you.
Okay. Hello, everyone.
Hi, Rebecca. Don't forget to introduce yourself.
Hello, can you hear me?
Yes, loud and clear.
Yes, my name is Rebecca Bello from Abuja. I work with the University of Abuja, Department of Community Medicine, and I'm a volunteer in the primary health care that was attached to the university for the doctors' training. So the climate change has really affected the community where we do carry out community diagnosis and we do visit them for health talks and others. So and even research. In the process of one of our research, that was when we come across a particular community along Kuje axis, that's Kuje Area Council. And the community, they were having issue of flood. But then, if the flood is over, it will wash away the whole farm produce. And then again, leave them with disease because they don't really have river in that community. It will create some kind of stagnant water pond all around them. And that is where they have their drinking water. That's where they breed their animals. They do all their activities, both human and animal activities take place there. And it was the same community that we discover FGS, the high level of FGS, because most of the especially they were complaining to us of how they use for concern. And in fact, we are still planning on how to revisit the community and
all right. Unfortunately, I think we're losing Rebecca. This sounds like a Nigerian telephone network when it does not want to work. But we got the gist of it. Really interesting, the connection you made to female genital schistosomiasis. So that's FGS, and that is actually the topic for the next session, which will be starting in 16 minutes. I believe we've completely lost Rebecca, unfortunately. All right, let's go to, let's see. All right, so our rules of equity, Charlotte, say that after a Nigerian speaker, it should be someone who is not from Nigeria. So if you are from a different country, please, we'd love to hear from you. The question is actually very simple, we hope, but it's complex unraveling it. Do you consider climate change a threat to the health of those you serve? So let's go to, let's keep trying. We have...
Earlier on, Unziku Tolbeck had his hand raised. I don't know if, and I'm sure he's not, I hope he's not from Nigeria. So there was also Hassan Balde.
All right, let's keep going, and we'd love to hear from you, Hawa Buhari. We know many of you are committed leaders for immunization. Let's go to Atahir Abubakar. And we're proud to have such a large, active, and dynamic Nigerian community, just so there's nothing equivocal about that. We just want to ensure that participants from as many countries as we can, that their voices are heard as well. So let's go to Atahir Abubakar from Nigeria, and then we'll go to Iseani. And we encourage, of course, gender balance, which can be hard to achieve. But Atahir, how do you answer this question? Don't forget to introduce yourself, please.
Okay, thank you, Reda. Good morning, good afternoon, good evening. I'm Atahir Abubakar from Nigeria. Climate change has a big threat to the health of those we serve in a variety of ways. Though I've put some on the chat box, in agricultural areas, because of the drought, most of the communities now cannot the yield is very minimal, very poor, and cannot feed the communities. So they end up begging, malnutrition has started setting up in some of the community because they cannot afford to feed themselves even 2 square meals. So the moment there's malnutrition, we know the health condition of those community is at risk. Then secondly, the climate change has caused some of in the urban areas where there's heat waves, pollution has set up. Just last week, I think even me, I was seriously down with asthmatic attack because of the pollution in the environment. So a lot of people have been complaining of having upper respiratory tract infection of recent because of the pollution, and which has been attributed to the climate change globally. Thank you, Reda, and over.
Thank you very much indeed, Atahir Abubakar. We have Bernard Bediako, who is going to be our next speaker. Bernard, your hand is raised. We'd love to hear from you. Is climate change a threat to the community that you serve as a health professional? First, introduce yourself, tell us what you do, and tell us maybe a little bit about the community that you serve, whose health needs you serve.
Okay. Thank you very much, Reda. So my name is Farm Bernard Bediako. I am the District Director of Health Services for Amansia West District in Ghana, specifically in the Ashanti region, where Amansia West is one of the 6 deprived districts in the region. If you look at Amansia West, it's basically a mining area, both legal and illegal. And then also, we have very deplorable road network on tarred roads, virtually in the entire district. So with these two combined, and one challenge we have is that because of the mining practices, we have a lot of uncovered mining pits, as well as lands that have been left devastated as a result of the mining. And so as a consequence of this, you would realize that when you look at our top 10 morbidity cases, we have malaria as number 1, we have diarrheal infections as number 2, we have upper respiratory tract infections, and then intestinal wounds. And these are very much of concern to me as the District Director of Health Services. So what would I have to do? It meant that I have to engage the political leaders, the community leaders, the mining organizations themselves, and let them know the threats of the mining and then leaving the pits uncovered and the lands unreclaimed. And so through that, we have had a lot of engagements, and I'm sensitizing them on that. Again, too, we are having community meetings and then going to the marketplaces, as well as to the miners themselves, engaging them with the hope that as we continue with this education, they would be able to, as it were, do responsible mining, wherein you will have these morbidities coming down. So that is one challenge that we have. Because, with mining, they use a lot of chemicals. And these chemicals, when ingested, have a lot of health implications on the kidney, on the liver, and also would lead to deformities in some of the children or the babies that are born. So this is a challenge that we have. But through community engagement, we've realized that we have seen some improvement along the line. Thank you very much.
Thank you very much indeed, Bernard Bediako. And you've actually shifted us. This is a perfect transition because the second part of the discussion and the sharing of experience that we were hoping to have is around these two questions. Is one, what can you do as a health professional to support your community that is changing, that is facing these changes that are affecting their health? And what do you want your country and global partners to do? So for the next, the remaining speakers, we'd like to ask you these questions as well. It seems obvious that most of you do agree that climate change is a threat to the health of a community that you serve. Charlotte, back to you to help us find the next, maybe one or two, possibly three final speakers.
So Reda, we have Eziani Nwane Dinamba, whose mic is already unmuted. So I hope you don't want to respond to the first question, but instead to the second set of questions. What can we do as health professionals? So over to you.
Eziani, do introduce yourself first. Tell us who you are, what you do, and then yes, what in the face of these changes, unless you disagree and you don't think that climate change is a threat, you can skip right to these questions, please. But do introduce yourself.
Good evening all.
Yes.
Can you hear me?
Yes, loud and clear.
Okay, my name is Cesar Anthony Nwane Dinamba. I came from Nigeria. I am a sustainable advocate and climate actor. I'm also ambassador to Geneva alumni. I'm very happy to be here today. The question, and also I'm also administrative officer at the Federal Polytechnic here in Nigeria. The question that I'm going to ask is that the effect of climate change on the health of us, everyone. We all know that climate change is a change in weather and temperature over a long period of time, but because of human activities, it happens often. And those human activities are the increase use of coal, oil, and gas, and also increase in population, and most important thing, it causes a lot of, wildfire, drought, land degradation, and also flooding. Most important thing is flooding that's happening right now within some of our communities and causes a lot of problems in terms of clean water and sanitations, where the children's drinking waters, and if that waters are not clean, it affects them, causes a lot of waterborne disease to them. So it's an adequate and most important thing that we need to come together to combat the climate-related issue as a threat to us. The second question, what can you do as a health professional to support your community? Most important thing for health professionals is networking, coming together as we are here today, sharing experiences and the knowledge gained that will facilitate us in all the challenges we are facing as health professionals, where we come together, work as awareness volunteers in our communities to reach the zero-dose children wherever they are, find them, knowing that a lot of zero-dose children in our community, but to find them is difficult because some people don't have the strategy how they can locate them. But we know there's thousands of them, and as health professionals, we need to come together, work in a common purpose to bring out all the zero-dose children around our community. Most important thing is building a capacity building, networking workshop, and also have experience sharing as we are doing today. It will help us to support our community in terms of health. The second one say, what do you want your country and global partner to do? Most important thing, in my country, Nigeria, we need a vaccine. There's a lot of zero-dose children in our country that we need to work on. We need to find them in the far north, in the far east, in the west. There are a lot of them, millions of them. So we, as the movement ambassadors, we must try our best to locate them wherever they are, knowing that those children haven't taken vaccine before, and most challenges sometimes is the we need to get their parents, contact their parents and go to house to reach them. And most importantly, because we know that this time things are very difficult and transportation are very, very difficult for some parents. So if you can able to bring any program closer to this community and bring them together, I think they were able to, mostly to fight vaccine hesitancy and lack of confidence in vaccine, so that we will get all these zero-dose children within our country. Thank you.
Thank you very much indeed. Now we only have less than 5 minutes left, so maybe Charlotte, we shall hear from one more person. Is it Hawa Buhari or Lucy Adebayo? Charlotte? All right, and Charlotte herself may be having connectivity issues. Hawa Buhari, I would love to hear from you.
Okay, good evening or good afternoon, good morning, wherever we are. It's good to be here. I'm Hawa Buhari I work on the UNICEF project in Sokoto, Nigeria. And okay, 2 questions I will ask. As a professional, I think you should begin to prepare.
I am very sorry, Hawa, but there's a problem. Yes, unfortunately there's a problem with your line. It's a very choppy sound. Charlotte, can you confirm it's the same for you?
Yeah, it's the same for me. Red, I don't know if you're using a headset. Maybe you.
Is there a way you can fix your microphone? We'll try to come back to you. In the meantime, we'll go to Lucy Adebayo. Lucy, a warm welcome to you. Tell us who you are, what you do. It's still choppy, so there does seem to be a problem with probably your microphone or the line that you're on. Lucy, a warm welcome to you. How if you can fix that, we'll come back to you. But we have only a few minutes left. I suggest you share in the chat. Lucy, introduce yourself. Remind us who you are, what you do, and then what do you consider you can do as a health professional to support your community, because these changes, health effects of climate events, are already happening. So 2 questions before you.
Okay, hello everybody. My name is Lucy Adebayo. Can you all hear me?
Loud and clear.
Okay, I'm a pharmacist and a public health practitioner specialized in health promotion and disease prevention. Am I clear?
Yes, perfectly. You're coming in perfectly. Can you tell us? Tell us if you disagree that climate change is a threat to the health of the people who come to your pharmacy to pick up their medicines, and that you advise and counsel. And what can you do as a health professional to support a community as it's facing some of these changes that are likely climate related?
Okay, thank you very much. I would like to state that this is my first time here, and I have learned a lot attending today. What I can do as a health promoter is to continue to educate members of the community. Everyone needs to be aware of the negative impacts of climate change. It's funny, and there should be this multi-sectorial approach to solving these problems. Only the health sector cannot tackle it. So all sectors should come together and make it a priority. Thank you.
Thank you very much indeed, Lucy Adebayo. And we're going to offer a round of applause to you, Lucy, because this was your first Teach to Reach. That is how we do it. And a warm welcome to the Teach to Reach family. We're going to announce the date for the next Teach to Reach, which will be in March 2024, very soon. And we hope you'll be with us. You'll come back for more learning and sharing of experience. I also want to acknowledge the great messages in the chat. Some very interesting comments. Ismail Farouk Umar, who says climate change largely contributes to malnutrition, other disease outbreaks. Now, one thing to keep in mind is there were disease outbreaks and malnutrition before the climate changed. So keep that in mind. It's extremely difficult to unravel the causal relationship, the cause and effect relationship between the two. But there are undeniably, and you seem to be confirming it, ongoing changes. Ismail Farouk gives a specific example from Gombe State of a high incidence of snakebite. That is it for this session on the health impact for local communities and the front lines of climate change. But there is more, because we are now going into our final plenary session for Teach to Reach. It's been a very long day for those of you who've been here since the morning. We appreciate your patience, and we know that many of you have been waiting for this session on neglected needs of women's health. We invite all of our guests of honor to stay, even if they are not familiar with female genital schistosomiasis, which is going to be the topic of our next session. So wonderful to have you here. We're going to start by asking Charlotte, what is female genital schistosomiasis and who does it affect?
Thank you, Reda. So, female genital schistosomiasis is an infectious disease that affects mostly women, and it's one of the most neglected tropical diseases. Over 56 million women and girls in sub-Saharan Africa are affected. And in 2021, with Bridges to Development and the FAST package, we launched 2 workshops in French and in English on female genital schistosomiasis. And this year in May, we had the opportunity with Bridges to Development again and the End Fund to do the workshop in the French language. But as we know that we have a community, an FGS community of over 6,000 primary healthcare professionals, some of whom are part of our immunization network, that have been doing some work to fight against this disease, and that is why we have this session here today.
Wonderful. I also want to introduce Nicole Vecchio from Bridges to Development, our partner for a lot of the work around neglected needs of women's health and specifically female genital schistosomiasis. We'll come back to Nicole as a guide on the side as we hear, and she'll be sharing resources and tools. We're also, and there are also many partners. We had Dirk Engels, who was here this morning for the Francophone sessions. We're looking forward to a great discussion. And as always, Charlotte is going to kick us off. Who shall we hear from first on this topic?
Thank you very much, Reda. So I invited Brigitte Megan. She is French speaking, but she has a very powerful experience to share with us around female genital schistosomiasis. So if you allow, she's going to share her story, and I will be play the role of interpreter, if that is okay.
Right. Yes. We've never done that before, but that's what we're all about. Okay. And Brigitte, okay. Soyez la bienvenue. A warm welcome to you.
Ok, merci Reda. Je reviens encore une fois de plus. Moi, je suis Brigitte Megan, je suis professionnelle de santé et j'exerce dans une structure hospitalière depuis la région du centre au Cameroun.
Okay, so she introduced herself. She's Brigitte Megan. She's a health personnel working in a health facility in the central region of Cameroon.
Voilà, merci. J'ai fait la formation sur la BGF à la Fondation Apprendre à Genève. Et
I participated in the FGS training that was organized by the Geneva Learning Foundation, and
je l'ai fait par curiosité. Et j'y suis restée par conviction.
I participated out of curiosity, but I stayed on in the training because I became convinced.
Voilà, je suis restée par conviction. Pourquoi? Parce que après la formation, j'avais une proche qui présentait des signes dont on nous avait parlé pendant la formation.
So the reason why I stayed on is because during the training, I learned a lot, and I had someone close to me who presented signs and symptoms of what I had heard of during the training.
Cette proche, avec des saignements ininterrompus, elle saignait pendant 2 ans. Elle a saigné pendant 2 ans.
So this person close to me had been bleeding non-stop for 2 years.
Elle avait des saignements par caillot. Elle a commencé par notre structure hospitalière sans suite.
So she had moved from several health facilities. She was bleeding profusely, in lumps, and the shift was started by visiting our health facility.
Après la première consultation, on lui a demandé les examens comme l'échographie. Elle a fait aussi le frottif cervical et d'autres examens encore.
When she came to our facility, they asked her to do some tests. They did an echography, an ultrasound, and they also asked for a cervical swab. So she also did that.
Tous ces examens sont sortis négatifs.
And
et rien
all
ne
the
montre.
results were negative. They couldn't know what was disturbing her.
Pendant ce temps, elle saignait toujours. Le saignement continuait.
And
elle se vidait de son sang.
She continued bleeding.
Elle se vidait progressivement de son sang et elle se fatiguait.
And she was getting very tired because of the bleeding.
Elle a parcouru plusieurs médecins sans
She visited several medical doctors, even gynecologists, without having a solution.
À la fin,
At the end,
le dernier médecin a juste souhaité qu'on lui fasse l'hystérectomie pour la sauver.
So at the end, the last doctor just said they needed to carry out a hysterectomy in order to save her.
Comme elle avait déjà beaucoup souffert, on attendait qu'on réunisse les fonds pour l'opération.
And since she had suffered a lot from this, so the family was trying to gather the funds to pay for the surgery.
Mais le Seigneur avait permis et avait mis la fondation à Genève sur mon chemin pour cette formation.
But thankfully, I participated in this training on FGS.
Et directement, après cette formation, je l'ai appelé, j'ai dit, bon voilà, peut-être les signes que tu présentes, c'est la bilharzio génitale.
So after the training, I called her and said, these signs that you're presenting, maybe you are suffering from female genital schistosomiasis.
Elle était très contente et elle m'a seulement dit, s'il y a les médicaments, si on peut traiter, sauve-moi.
So when I told her that, she was happy and she said, if there are any drugs, if there's any treatment for this infection, please help me.
Voilà, c'est comme ça que je me suis battue pour trouver le praziquantel.
And that's how I tried my best to get praziquantel for her.
Et par rapport à son poids, elle devait prendre 6 comprimés.
So with regards to her weight, she was supposed to take 6 tablets.
Comme ça faisait beaucoup de comprimés, je lui ai dit de prendre d'abord 3 le matin et 4 heures de temps après, elle reprend encore les 3 autres comprimés.
So she took the tablets, not 6 at once because that was too much. So I told her to take 3 and take another 3-4 hours later.
3 jours après, le saignement a commencé à diminuer.
3 days later, the bleeding began to subside.
Au 5e jour, le saignement s'est arrêté.
On the 5th day, the bleeding completely stopped.
Elle n'était pas sûre. Elle avait peur. Elle se disait que ça devait recommencer.
So she was not very sure. She was scared, thinking that it was going to come back.
Elle ne s'en revenait pas. Elle ne croyait pas que ça pouvait être vrai.
So she was very shocked. That is, after 2 years of bleeding in the space of 5 days. So to her, it was unbelievable.
Nous avons patienté. Je lui ai dit de patienter et qu'on essaye d'observer.
So we asked her to be patient. We are going to observe again.
Nous avons fait 8 semaines et je lui ai demandé de prendre encore la 2e dose pour mesure de prudence.
So after 8 weeks without any bleeding, but I still asked her to take a 2nd dose of praziquantel just to be sure.
Parce qu'elle était tellement inquiète, elle avait peur que ça ne revienne.
Because she was very worried, scared that the bleeding was going to come back.
Après les 8 semaines,
so after
et après la 2e dose,
after the 2nd dose,
elle n'a plus jamais eu de saignement.
She has never had that problem of bleeding again.
les règles sont revenues à la normale. Elle saigne normalement les 3 jours qu'une femme peut saigner et ça s'arrête, ça ne lui crée plus de problème. Elle n'a plus aucun problème de saignement depuis 2 ans qu'elle souffrait de cette bilharziose dans le silence.
So, and even her menstrual cycle returned to normal. So she stopped having this problem of bleeding that she had suffered from for 2 years in silence.
Et après ce cas,
So after this case,
oui, je suis allée en parler avec mon chef.
I went to to talk about it to my supervisor.
Et on a conclu qu'on devait former tout le personnel parce que ce cas était passé d'abord par chez nous.
So I told her about the case and the training that I received on FGS, and she said we have to train all the personnel at the facility because they were the first to receive this case and couldn't handle it.
Voilà, comme personne n'avait pu détecter de quoi elle souffrait, on a dit c'est très nécessaire que tout le monde se fasse former.
So we decided that it was necessary for everyone to be trained since we were not able to diagnose what she was suffering from initially.
Et c'est comme ça que tout le monde s'est allié et on a organisé une formation. Mais avant la formation, on a fait des prétextes.
So that's how everybody joined the training. And before the training started, I administered a pretest.
Et pendant le prétest, on a constaté que sur 80 personnels, 2 seulement avaient déjà entendu parler de la BGF.
And when we evaluated the pretest, we saw that out of 80 people, only 2 had heard about FGS, female genital schistosomiasis.
Donc, c'était vraiment une chose vraiment étrange.
And so to us, it was strange.
C'est comme ça que nous avons fait la formation.
That is how we did the training.
Tous les médecins, les laborantins, les infirmiers, ils étaient même très contents pour suivre cette formation.
The nurses, the laboratory technicians, the medical doctors, they all took part in the training and were very happy.
Après cette formation,
after the training,
tout le monde était déjà capable parce qu'ils ont fait cette formation avec passion.
Everybody was now capable of that because they had participated in the training with passion.
Oui, ils avaient la passion parce qu'ils avaient eu un cas palpable sur la main et chacun était vraiment intéressé et chacun cherchait aussi dans son entourage une personne qui avait ce genre de problème.
So they were passionate because they had seen the case, they knew about the case, and they also went about looking in their entourage to see if there were people that they knew that were having this same challenge, this same problem.
Oui, c'est aussi comme ça que beaucoup de collègues sont revenus vers moi pour faire leur confidence parce qu'elles aussi, elles souffraient aussi de la bilharziose sous silence.
And that's how so many women, they also came. I meet some colleagues, they came and they broke the silence because some of them were suffering the same issue without talking about it.
Beaucoup ont pris aussi ce médicament.
And many, they took praziquantel.
Et elles ont retrouvé aussi leur guérison.
And they were healed, they received their healing.
Notre chef a fait un effort pour mettre le praziquantel gratuitement à la pharmacie.
So our supervisor, the head of our health facility, made efforts to make praziquantel available in our pharmacy.
Pour que chaque malade, ou bien chaque personne qui souffre de cette maladie soit capable de se faire soigner sans difficulté.
So that if anyone that is suffering from this disease, if they visit the health facility, they can be treated without any problems.
C'est devenu une union au centre hospitalier parce que quand il y a même un cas, C'est-à-dire, même le médecin doit courir rapidement, venir vers moi et dire, bon, voilà, nous avons un cas qui, le malade fait ceci, fait cela. Je pense que c'est ce que tu nous as enseigné là. Je pense que c'est ça. Et puis, ça me fait plaisir vraiment et on s'associe pour sauver des gens.
So it has become a unifying factor in our health facility because each time there is a case, even the chief medical doctor, she will come to me and say, this looks like what you trained us, and we will join our heads together to take care of the case. And I am very pleased with that.
OK. Et je pense que vraiment, voilà à peu près les bénéfices de la formation.
So that is in a few words what I gained and the benefits of this training. Merci beaucoup, Brigitte. Thank you very much.
Merci beaucoup.
We thought this story was exceptional enough that we would translate it for English speakers. Brigitte shared it this morning with francophones. And we thought it was interesting enough to bring to your attention a concrete case of how, in which this female genital schistosomiasis stopped being a neglected need of women's health in a particular context and in particular circumstances. I'm pleased to welcome, and apologies I hadn't seen her when I checked, she wasn't yet in the room and joined right after. Julie Jacobson is a doctor, gynecologist, public health specialist and longtime advocate and change maker for female genital schistosomiasis. A warm welcome to you, Julie. You just heard this story translated thanks to Charlotte from Brigitte Megang. What does this? Yes, could you introduce yourself and tell us what's on your mind when you hear a story like that, and how exceptional is this story of change in a local health facility for you?
Well, the story is just so compelling, and so I want to thank Belinda for sharing that and being brave enough to share a story like this, because the challenge is the lack of knowledge. And so this is a parasitic infection that comes from contact with fresh water, and the parasite gets into the pelvis and creates this inflammation, which can cause bleeding, as we heard in this story, also vaginal discharge. It can cause an increased risk of the acquiring HIV infection due to the inflammation, and it can cause infertility. So this is a broad range of things that can happen in women and girls just because they had contact with fresh water, swimming, bathing, washing clothes, getting water for the family, for the household. So it's really important to increase the awareness of it and sharing your knowledge, as you just demonstrated in that incredible story, so that others know as well, so women and girls can get this very simple treatment of praziquantel. A single dose of praziquantel can help remove these symptoms and cure the parasitic infection. And so this is exactly what needs to happen, and this is exactly why we want to share this information. It is not a sexually transmitted disease. It is from contact with water. The parasite actually penetrates the skin, gets into the body, and then lives within the pelvis. And that's where they produce these eggs, which go out and cause that inflammation. And so this is a solvable problem, and it's a knowledge gap. And as we hear that people really, once you know, you can take action immediately within your communities. So the story you heard is not an uncommon story, where women go and have hysterectomies or chronically treated for sexually transmitted infections that they do not have, or are accused of being sexually promiscuous when they're not. So it's not an uncommon story, the suffering, but the action that you can take is really what's compelling here. So I'm very excited to hear your stories and to help spread the word about female genital schistosomiasis, so that we can solve this problem and relieve that suffering. So thank you
so much
having me here and being part.
Dr. Julie Jacobson, longtime advocate, and Julie came to us in 2021. Raise this issue of FGS. We called on our immunization community, asking you if this is something that you would be interested in learning about, and you responded massively, both inside and outside of immunization. The best way to access all of the many resources is to go to the Geneva Learning Foundation's website. You find the special event on tackling FGS, and you'll receive a number of resources, including a really important one, frequently asked questions that actually came out of the workshop. But I actually want to tell you a little bit more about that. In May and June 2021, over 300 healthcare professionals in sub-Saharan Africa participated in the Fast Package workshop on female genital schistosomiasis. So this was Bridges to Development, came to us at the Geneva Learning Foundation, invited us to contribute to this effort, and working together for the first time, these health professionals, this is 2021, developed 213 practical, feasible plans for local solutions to tackle FGS in their context. Now, I'm pleased to say for the Francophones, and unfortunately, we'll keep the Anglophones waiting longer today, our community of around FGS has grown to over 6,800 health practitioners. A little around half are from immunization, but the other half are from many other areas. And we are about getting ready to launch for the Francophones, for the second cohort of the Francophones, what we call the Impact Accelerator, which is really a human knowledge network uniting scholar alumni in a shared pledge to turn knowledge into action. To give you a sense of what this pledge that people who participate, who successfully complete the workshop, are invited to make in order to then focus on actually taking action. I'm going to ask Charlotte to read this pledge so you can get a sense of what this is about.
I am committed to work for a world where everyone, everywhere is protected from neglected tropical diseases and especially female genital schistosomiasis. As a scholar, I hereby solemnly pledge to work with others to transform projects led by scholars into action and results that will improve health outcomes. Share my success as well as my challenges by reporting on a regular basis on my progress towards implementation, and support fellow scholars in doing the same while upholding the highest standard of integrity and behavior. I make this pledge to contribute to the global goals for the health of women, men, girls, and boys in my country and everywhere.
So when you participate in the FGS workshop, at the end, if you successfully complete the workshop, we invite you to take this pledge and add not only a commitment that you have as a health worker, but also a moral commitment to actually getting to the results, getting to impact, and making that difference. When we asked participants in previous impact accelerators, this is what you told us were the most valuable aspects: collaboration with country colleagues, learning from other countries, focus on action in the field rather than theory and planning, regular reporting to stay on track and focused on impact, and knowing that scholars share that same pledge that each and every person has made. Now, this is about mobilization, momentum. It's also about healthy competition, networking, overcoming difficulties, and leveraging resources. Now, we only have 7 minutes left in the session, but I am going to turn to Charlotte. I know that there are many other FGS workshop alumni from 2021 for the Anglophones who are, I believe, in the room with us and would love to hear from some of, at least a few of them. I see Rukaya Mumuni from Ghana has her microphone already ready to go. Rukaya, tell us, you are an immunization worker. You work for the Ghana Health Service. How did you end up getting involved with female genital schistosomiasis? And do introduce yourself.
Okay, Rida, thank you so much for this opportunity. Hello, everyone. My name is Rukaya Mumuni from Ghana. I work with Ghana Health Service, and I work at the subnational level. Basically, I do immunization. So my work, about almost 99% of my work is vaccination. But I am part of the Geneva Learning Foundation community. So when I got the opportunity, when I had the invitation to join, I never even heard about female genital schistosomiasis for FGS. So I was curious, because when I read about the statistics, I was so alarmed, because it affects a lot of women, and most health workers, me myself, for the first time hearing it, I never even came across it during my school nursing training, and during my further studies in nursing. I have never come across FGS. So I took the opportunity, and I took part of the workshop. And I had an action plan to engage community, because I do a lot of community engagement. I educate communities on vaccination and other health issues of nutrition. So it was an opportunity to me to educate my communities about FDS, and also to increase the awareness in the communities, and also to educate other health workers, because if myself I'm not aware, meaning a lot of us are not aware. So it was part of the action of my action plan to raise awareness on FDS. And along the line, we had the opportunity to be trained as first subject matter expert. Actually, it was a very great opportunity for most of us who took part in the FDS training on the online workshop. And we had the opportunity to meet Dr. Julie in Ghana. That took us through more comprehensive training on FDS and how to integrate FDS activities in the healthcare delivery. So it actually motivated me. It actually gave me that encouragement to go ahead and then make sure FDS activities become known in the hospital. So I took it up, and luckily for us, I met some of my colleagues at the training. We were about 3 of us that were coming from the same facility that were part of the in-person training in Accra. So we teamed up and we took FDS back to the district and trained most of our staffs on FDS. I work with a lot of community health nurses in the community, so I trained them. Then I made sure in one of our meetings as preventive health nurses, I raised the awareness. I created awareness on it, and most of them were not aware about FGS. So it actually increased awareness among health staff within the district. And after the training, I realized one of the nurses came up to me, Rukaya, I have been having this issue for a long time. Most of the symptoms, the signs that you have mentioned, most of the signs that you mentioned about, or you trained us on FDS, I have been experiencing it. She had this repeated vaginal infections for over years that is unresponsive to antibiotics. Then she also have issues with conceiving. She has been trying to conceive for a long time and she's not able to conceive. So she told me, and she also mentioned that she had contacts. During her childhood, when she was growing up, she was living in areas where she had contact with freshwater bodies. So it was a clear sign. It was a clear indication that she might be suffering from FGS. We quickly gave her the treatment, and she took the first dose of praziquantel. And after some months, about like 2 months time, she came back and she told me that the signs, all the vaginal discharges that she was experiencing, and it was not responding to antibiotics, has disappeared all of a sudden. And that was one of the greatest stories. So all of us who were involved in the FDS training were so happy that we were able to identify a case even amongst health staff that we were able to treat. So I think FGS, what we are trying to do now is to integrate it with cervical cancer screening. You know, FGS can complicate cervical cancer. So we have screening, we do screening at the hospital. So I have sensitized myself and the doctor that took part in the training. We have sensitized the staff that is engaged in carrying out the cervical cancer screening to be able to detect if somebody is unresponsive or is negative for cervical cancer screening, but have lesions, then we should suspect and then maybe treat for FGS. And that is what we are doing. We are actually making sure that every health staff is aware, so that we'll be able to increase them suspicion of FGS and we'll be able to treat it. And I was so happy when I met Dr. Julie at the Women Liver Conference. We teamed up to raise awareness and to make sure that policymakers, especially when it comes to cervical cancer treatment, we integrate FGS into cervical cancer treatment and then screening effort, so that we'll be able to make impact, to be able to screen more people, to be able to get more people treated with FGS. And so far, this has been my story about FGS.
All right.
And
it sounds like an amazing story that's only just beginning. I do want to turn to at least one more person, if Charlotte will allow me to go over time. We've both been facilitating since around 7:30 this morning. So Rebecca Bello shared an experience. For some reason, it's kept some of the drafts we have are confidential, but would hear. I hope, Rebecca, I know you've been with us all day as well. Rebecca, you shared from Kuche area in Abuja. Yes, a story. You said FGS awareness is work I always do in rural communities, and I also encourage women to go for urinary tests at the hospital. We already have a case of a rural community in Kuche area of Abuja that needs attention. Can we finish with this story, your experience of tell us what happened, what you did, and how it turned out.
Okay, thank you very much. My name is Rebecca Bello, once again from University of Abuja, Department of Community Medicine. I am a medical laboratory technologist. So one of our medical students, a resident doctor to be precise, is running his master's in public health in our department. And I discussed, because I was introduced to FGS from the Geneva Learning Foundation, because myself, I never knew that women can be infected with schistosomiasis, they can have that disease. So until when I learned from Geneva Learning Foundation, I was now sharing with some of the resident doctors, and two of them picked interest and decided to carry out research on that particular disease. So we decided to visit this particular community in Kuje. We decided to go there because we know that they usually have problem of water and other things, and they are male. They have this particular disease. There was a particular research from that community that shows that the men have that schistosomiasis disease. So we decided to go there and check the female. And after we did all the community entry, we visited the village head and the rest. They granted us access to the women. We now mobilized them and started educating them on this FGS. And some of them, being like me, I'm the one that usually speak more of the local language there, the Hausa language. So when we were talking to them, and the girls decided to have a session with them. So they open up to us about their problem, if they are urinating, how they usually see blood. They thought maybe it's part of a woman to see blood in the urine because they menstruate. Unfortunately, they didn't know that they were having that infection. So we decided to collect their urine samples and stool. So I came back to the lab. We were able to collect 382 samples of urine and stool. Lo and behold, the urine was something else. We were seeing the ovaries of schistosoma hematobium in their urine, the female. As I was carrying out the work, I was like, I've never seen. Because if not that I went there myself, I would deny that it's not from a female. But being that I was there, I saw it myself. The specimen carried blood. It was something else. But at the end of the day, we forwarded the report to the committee, that there is a particular committee that belongs at the teaching hospital. They are part of the Nigerian Society of Female Genital Schistosomiasis, Society of Nigeria, something of that nature. So I've not joined the Nigerian faction anyway, but I'm hoping to join them in their next meeting. So we forwarded the report to them, and they are working on how we are going to go into that community for intervention.
Thank you very much indeed, Rebecca Bello.
I think that's where we...
That's a remarkable story. One of many and a growing number through this collaboration. Bridges to Development came, and actually we you already knew each other, but decided to work with the Geneva Learning Foundation to develop, to see if we could scale a program. Initially was supposed to be focused on Madagascar and Ghana, and we said, well, could we include participants from other countries? It will not cost us any more to be more inclusive and to open up access. And you've heard some of the results today from some of the countries that were not in the original plan. I'd like to turn to Julie Jacobson. This is, Julie, something that you've dedicated very much of your energy, your professional career. Would love to hear your parting thoughts. What's next for FGS, and what are you taking away? For you, it's the morning after this session. Would love to hear some final reflections before we close.
I think for me, the power is the power of the people that are on this call, and you all that are taking action. The compelling stories and sharing this knowledge, and the fact that you are all seeing this. The challenge has been that this doesn't get reported, and so it doesn't officially exist. And here we hear about all the silent suffering that's gone on. So for me, you're inspiring me. I'm here at an infectious disease conference in Boston, and then going to Chicago for another tropical medicine disease meeting, and I'm going to share this information with the people that I meet. And I appreciate all of you doing the same and reaching these women and girls with this inexpensive single-dose treatment that can reduce a lot of suffering. And so I'm inspired by you and hope to continue to do this in any way that I can help serve this population, and hope to be a part of the solution as you all are. Thank you.
Wonderful. Thank you very much, Julie Jacobson. Thank you. And that is a wrap for Teach to Reach 9. I can't believe we hadn't had this many sessions, Charlotte, since for a very long time. And very glad that we did do these sessions in French and in English on female genital schistosomiasis, in addition to the immunization topics that are the heart of Teach to Reach. We'll look now at our schedule. You can see that there is one item left. We're going to close this plenary, but you have 2.5 hours remaining to participate in networking. Again, the networking, you have to go to the platform, the Teach to Reach 9 platform called Hopin, or now it's called Ring Central, but whatever the name, it's our platform. You join now the speed networking. You click on join. You do have to authorize the audio settings. If you haven't tried this, it's really one of the best parts of Teach to Reach. I'm not sure at this late hour how many people are left, but we did want to offer that additional time for Teach to Reach. All right, we'll be collecting your final comments. We're going to add some music here. And thank you once again. It's been an amazing 9th edition of Teach to Reach. We're thinking of splitting up doing French and English on 2 days as we continue to expand the program and the number of partners and donors that are contributing to sustain Teach to Reach in the future. So keep an eye peeled on your inbox. Do read our messages. We know in some cases there are many messages that we send your way, but we look forward to continued engagement and commitment, and sharing more amazing stories in the future at Teach to Reach 10 in March 2024. Once again, thank you and goodbye. To thank, of course, our guests of honor, those of you who have stayed in this room for the entire day, I think, and grateful for those of you who stayed, including the non-immunization topics. Thank you once again.
Reda, we have Rebecca Bello that started with you and I in the morning in the French session.
True. Yes. That's it. Thank you to all our guides on the side as well. What an amazing event, a series of events. We hope that this will be useful to you, to your learning. for progress in the future. And for those of you who work in immunization, on childhood immunization, who work with children, of course, we have these pictures that mean a lot to us.